Good morning, everyone. Am I audible?
Yes,
Yes,
ma'am.
ma'am, you are audible.
Is my screen visible?
Yeah, it's
Yes,
visible.
yes.
So shall we wait for another 5 minutes?
Yes, ma'am. Start around 9:01, 9:02. Okay.
Okay.
Yeah.
Hello, hello Prerna ma'am, can we start?
Yeah, we can. Yeah. Okay, so a very good morning to all of you. And at the outset, I would like to thank Dr. Neeraj Jain and all the organizing team for giving me this opportunity to speak on this wonderful academic forum. So we'll start our Sunday with the pre-analytic quality assurance in hemostatic lab. So what is quality? So quality, according to the International Organization for Standardization, has been defined as a degree to which a set of inherent characteristics fulfill the requirements. So, and the lab's quality control program is definitely a critical component of the quality assessment. Not only it monitors the testing process to ensure that reliable test results are obtained, it also detects the problems which are within the testing system and allow the correction of these problems before the patient results are affected. So quality, the main aim of quality is right test for the right patient, and also in hemostasis, it is very, very pertinent to do at the right time. And of course, the right management. So we are all aware of the quality assurance cycle, which begins from the pre-analytic factors, the analytic factors, and the post-analytic factors. Now, at what time point the pre-analytic factors begins? This begins right from the clinician prescribing the test for the patient. And this is also very, very important to know in the hemostasis that the correct test or orders and also at the correct time. And we will see in the subsequent presentations. So as we can see, the pre-analytical factors, they are the major factors which contribute to the lab errors. That is, they constitute around 46 to 70%, which is followed by the post-analytical errors. And now with the automation coming up, of the automation and maintaining the quality of all our equipments and the reagents, the analytic factors are markedly reduced. So some of the pre-analytical errors which we begin right from the clinician ordering the test to many patient variables, as we can see, to correct identification, labeling of the samples, a non-traumatic sampling, what is the correct order of the sample, the hematocrit adjustment, the sample transportation, and other variable interfering factors, and the processing and the storage. So all these become very pertinent in the hemostasis lab. But to begin with, what is hemostasis? So in general term, when we say hemostasis is just a bleeding disorder, but it is much more than that. It is a complex process, which includes not only in the bleeding disorder, but the clotting cascade also, as well as the fibrinolytic pathway also. So it is just not simply a bleeding disorder. It includes the coagulation and the fibrinolytic mechanism. And now we have progressed to the cell-based model of hemostasis, which begins that all the process they are occurring simultaneously on the activated platelet surface. So here again, I want to stress this fact that the coagulation pathway, all these hemostasis is occurring on the platelet surface. So this must not be forgotten that the platelets constitute a very, very important component of the hemostasis. So let's see what are these variables in hemostasis. That begins from the clinical person describing the patient test to the appropriate clinical history, sample collection, which will include many patient variables and the appropriate time of collection, the specimen transportation, stability, specimen processing and storage, as well as many interfering factors. So let's see how the clinical history plays a very important role in hemostasis. Now, to take a very good bleeding and coagulation history is a prerequisite for any hemostasis lab. So it is also considered to be the best screening test for the risk of bleeding and the coagulation. So we can ask various questions pertaining to spontaneous bleeding, or how the bleeding is occurring after trauma, surgery, or any operative intervention, whether the patient is requiring multiple blood transfusions or not, and the ease with which the bleeding is controlled. IT section, can I please stop your audio? So the spontaneous bleeding to bleeding after trauma, need for repeated blood transfusions, and the ease with which the bleeding is controlled, and particularly in the female history, the simple history of menstrual history and the problem that should not be ignored. Drug history and family history is equally pertinent to take. Now, there are various for bleeding. There are various bleeding assessment tools, like we have a modified WHO bleeding assessment score, pediatric bleeding questionnaire, and ISHT BAT. Now, all these bleeding scores, more than telling the probability, they have a very negative predictive value. That is, if the scoring particularly of ISHBT BAT is less than 2, that makes the bleeding history unlikely in a patient. So all these, apart from bleeding history, the coagulation history in detail should also be taken and the points noted down in your history sheet. Let's see how the history plays a very pertinent role. For example, we have done an APTT, which says it's 70 seconds, which is clearly prolonged as compared to the control values, but there is no history. So how we are going to interpret this APTT of 70 seconds? If it is a 3-year-old child with joint swelling, this may suggest hemophilia. Well, the same case, if it is a 15-year-old female with menorrhagia and epistaxis, von Willebrand disease, 50 years male who is asymptomatic, it could suggest a factor 12 deficiency, while a 27-year-old female which has a history of recurrent abortion, this value of APTT means could be a lupus anticoagulant. Not only this, the pre-analytical variables, like if the sample is clotted, the clotting times is going to be prolonged, or if the sample is processed after a long time, the APTT is going to be prolonged. So which one of these holds true for the patient, we do not know unless we have an appropriate history. So without history, APTT, even if rightly performed, it is just a number. So clinical ordering and inappropriate requests. Yes, there are many inappropriate requests from the clinicians also, which contribute a very important pre-analytical issue. And it is our duty as a lab personnel to make them aware that what is the proper timing of these tests. So the proper timing is very important, but very, very poorly recognized issue. And we should not hesitate in telling the clinician that what is the appropriate time to do any hemostasis test. For example, following a thrombotic event, consumption of the natural anticoagulant take place. Therefore, if we are going to test the hemostasis too soon after a thrombosis, this will lead to false conclusion that it is a deficiency. And also we know that post-thrombosis factor 8 level rises, which may lead us to a misdiagnosis of lupus anticoagulant if we are using only an APTT-based screening test. So drug interference in hemostasis, there are a large number of drugs which interfere in the hemostasis, varying from heparin to your warfarin, vitamin K antagonists, the antithrombotics, the newer oral anticoagulants which are there. And the guidelines have described that what is the appropriate time to collect the samples for hemostasis once the patient is on these anticoagulants. For example, the patient is on heparin therapy. This will influence the antithrombin detection. While if the patient is on warfarin therapy and we are doing protein C, protein S, that is going to give us false low values of protein C and protein S. So it has been seen that up to 1/3 of the samples which are destined for thrombophilia, the investigations are from the patient of warfarin or heparin, because as soon as the patient is having a thrombotic tendency, the patient is put on the anticoagulants, and now the clinician wants that test should be done to determine what is the cause of thrombosis. However, the patient is already on warfarin and heparin. So these drugs are the very, very important problems in the diagnostic errors in any hemostatic lab. So they should also be diligently history taken, and only appropriate time which is there as on the basis of the drug history that should be taken. So let's see, there are many patient variables, and we all can wish that these are beyond the control of any laboratory errors. So however, these cannot be ignored. One just has to be very vigilant of the patient variables so that the appropriate result can be given to the patient. Let's see increasing age. So what happens in increasing age? There is increase in D-dimers, von Willebrand, and other factor levels. So what is important in hemostasis is to establish the age-appropriate reference interval. For example, a 4-day newborn which has an intracerebral bleed and the APTT is 54 seconds versus a 12-year-old male with an intracerebral bleed with APTT of 54 seconds. Are these both prolonged, or one is normal and one is abnormal? So let's see. So as the coagulation test values in different postnatal age varies, and we all know that in the till the 6 months of age, the liver is not mature. So vitamin A dependent clotting factors, they are already reduced. So as to having the prolonged values of the APTT. For example, if we take APTT, so this will be a normal for a day 3 child who has a range reference interval of 35.3 to 68.3 seconds. While the same case, if it is seen in a 12-year-old male, that is definitely abnormal. So at birth, the coagulation factors of full-term infants are around half of those of the adults. So therefore, lower levels of these factors will lead to prolongation of the clotting factors, and PT tends to normalize to adult level by 1 month. However, APTT normalizes by 6 months. So most of the dictum is that the adult level they reach by 6 months of age. So the age factor and the reference interval should not be ignored in giving the results to the patient. Another example, let's say your patient variable is the gender. So we know in females, there are higher levels of various factors. And also if the female patient is on oral contraceptive and hormone replacement therapy, the guideline says that the therapy has to be discontinued for 2 months prior to any hemostasis test. Similarly, von Willebrand disease in menstruating female, the sample collection has to be done on cycle day 1 to 4. In pregnancy, which is a great patient variable which affects many coagulation and hemostatic parameters, so tests are not usually recommended in pregnancy, and it is said that at least 2 to 3 months postpartum, the coagulation or the clotting-based test should be done only after 2 to 3 months postpartum. And we are all aware of the effect of blood group. In the patients of blood group O, there are lower levels of factor VIII and von Willebrand, so that we may misdiagnose the patient as having von Willebrand disease if we do not take into ignore the presence of blood group adhesion on the patient. And various health factors, there are innumerable health factors. Just to enumerate a few, like inflammation, it increases various factors. Stress, exercises also increase von Willebrand factor. And there are a lot many variables pertaining to platelet function tests, be it stress, exercise, fatty acids, coffee, caffeine. All these have to be taken into consideration before we contemplate these tests. Let's see another case. A 20-week pregnant patient presented with sudden onset of cerebral venous thrombosis, and a past history revealed 3 miscarriages at 2 to 3 months of gestation. So on the basis of this history, the clinician suspected presence of a lupus anticoagulant, and they requested us to process the sample. Though the processing was done, however, it came to be positive, and the DIVT test ratio became 1.8, which says a moderate LA positive. However, let's see what the guideline says. So guideline says that if anti-phospholipid testing is done during pregnancy, there should be caution, as both false positive and false negative lupus anticoagulant can take place, and they have to be done at the baseline level, that is 3 months post-delivery. So again, the repeat testing was done in the postpartum state, which became negative. So had this been given as a positive, the patient would have been subjected to undue further tests, as well as put on the therapy for lupus anticoagulant. So in this case, the result clearly was a false positive being done not only in pregnancy, but also you should know that the patient recently had a cerebral venous thrombosis. So in any acute episode, this has to be deferred for 3 months after the acute episode. So let's see other important pre-analytical variables like sample collection. Needless to say, excuse me, the patient identification and correct labeling of the tube is very important. And I have already stressed like the platelets play a very, very important role. So as soon as blood is withdrawn from the vessels, changes begin almost immediately, which will lead to activation of the platelet and leading to initiation of the clotting mechanism. So this point again has to be stressed that there should be minimal platelet activation while withdrawing the sample. For this, tourniquet should not be kept for more than 1 minute. And it has been seen that if it is kept for more than 3 minutes, then it leads to prolonged time and prolonged stasis with many variations in the various coagulation and the hemostatic factors. So blood has to be drawn slowly, also to avoid hemolysis and platelet activation. Another guideline which says this for the same reason to avoid hemolysis, that is 19 to 21 gauge needle should be taken in adults and 23 gauge may be required for infants. If we take too large a needle, that is which has a less than 16 gauge, or too small a needle bore, they should be avoided because both they can lead to considerable hemolysis. When they with the different bore needles, we apply pressure and put the sample in the vacutainer, that leads to hemolysis. And for the coagulation or the hemostatic test, we have to use plastic or the siliconized glass tube because the other surfaces can lead to rapid activation of the platelets. So sometimes the sample we find that we get the samples from the IV lines for the vascular access devices. Now, the potential problem of these is that there is a heparin contamination, and even if a little amount of heparin is there, that is going to cause marked prolongation of your values of PT, APTT. So this should be clearly be avoided. And also not only heparin contamination, but the sample can be clotted, hemolyzed, or activated. So all these lines have to be flushed with saline, and the initial 5 ml of the sample has to be discarded before you take the sample for the hemostasis. So we all know about the anticoagulant of choice. There is 3.2% trisodium citrate with 0.105 to 0.109 molarity. Now, why this has been chosen with the blue top vial, which we know is because of its stability and closeness to the plasma osmolality. Now, various other recommendations like 3.8 Also, people use 3.8. However, with the using of excess of trisodium citrate, it overestimates the PTA, PTT and underestimates the fibrinogen. So the recommendation is to use 3.2% trisodium citrate for hemostasis. If any lab is using 3.8, they should stick to 3.8, though the recommendation is 3.2. Though both are correct, but the 3.8 has to be not to be taken, and there should not be any interchangeable, should not be there. Like one time you are taking the patient sample in 3.2, the other time your vial is not available, you are taking it 3.8. That is a big no-no in any given lab, because both the citrate concentration will give different results. So this is to be avoided. And oxalate, heparin, EDTA, they are all unacceptable for hemostasis because there are many labile factors like factor 5, 8, which are unstable in oxalate, and heparin, EDTA, they irreversibly inhibit the coagulation process, and therefore with any clotting time point determination, they will interfere the values. And heparin, like I've already mentioned, it activates antithrombin, which is an inhibitor of the coagulation. So certain other tubes we can use for hemostasis are the CTAD tubes, that is citrate, thiophylline, adenosine, and dipyrimidamole. Now these are the special tubes and they have additives which prevent in vitro platelet activation. So basically we use it for the monitoring of the unfractionated heparin and the platelet factor 4 monitoring, as well as we can also use for platelet glycoprotein estimation by flow cytometry. EDTA and serum samples in hemostasis are used when you have to do the specialized test, like if you have to do the serological test for heparin-induced thrombocytopenia, or you have to do anti-beta-2 GPI or anti-cardiolipin antibodies for the EPLA. And EDTA, we all know it causes the agglutination of the platelets because of antibodies in the EDTA. So again, that is a big no for the routine hemostasis test. Now, another pertinent question is what is the order of draw while we are taking samples? So if you have to take multiple samples, then when should the coagulation tube should be taken? Should preferably collected before we do the collection of the other tubes. After blood culture, because of course the sterile conditions have to be taken in the blood culture. So that is the first, which is followed by the citrate, and then it is followed by the serum, heparin, ETT, and oxalate. Now, why this order of draw is important for coagulation? One, which I have already told you, that platelet activation starts right when you withdraw the sample. So to avoid that, as well as if we are using these tubes before, there is always some contamination by these anticoagulants. And even if little amount of heparin or the other clot activator goes, it will coat the rubber stoppers and contaminate the citrate tube. So again, with little of heparin contamination, the entire hemostasis test are going to go haywire with abnormal prolonged clotting time. So this has to be clearly and strictly be avoided. Tube fill volume. This is a very, very practical problem which we face in a hemostasis lab, that what should be the minimum volume should be filled. So tube should be adequately filled to mark and no less than 90% of this volume. So if you will clearly see the citrate vials, all of them have a minimum fill and the maximum fill indicators, which should be strictly be followed so as to maintain the appropriate 1:9 ratio of the anticoagulant to the sample. Now, different tubes, 2.7 ml, 1.8, both of them, they have their markings. So depending upon the volume of the sample tubes, there are markings, and this should be clearly be conveyed to all the lab staff as well as the clinical side, which are giving the coagulation sample. So what happens if there is underfilling of the tube? It increases the ratio, decreases the plasma volume and increases the ratio of citrate. And therefore, when the recalcification is take place, because already calcium citrate complex has formed, only a partial recalcification take place and the clotting times are prolonged. So this sample dilution due to underfilling should be clearly be avoided. And once we do overfilling, it causes the minor clot in the sample, which again is a big no for any hemostasis lab. Now mixing the sample. So once we have drawn the sample, manual mixing by gentle inversion 3 to 6 times is recommended so as to ensure appropriate mixing of the blood with the anticoagulant. But in hemostasis, if we do too vigorous mixing, like by shaking of the tubes, it again causes hemolysis or the spurious platelet and factor activation, which can lead to shortening of the clotting time and elevation of the your factor activity. And if the suppose one tube has a less volume and you want to transfer it to another citrate tube, can we do that? No. We should not be transferring from one citrate tube to another citrate tube just to fill the volume. That is not there, because this will lead to doubling up of the anticoagulant citrate levels and further dilution of the plasma sample. Let's see one another case is a 30-year-old male, cyanotic male, who is diagnosed with congenital heart disease, with breathlessness, high BP, presented with recurrent epistaxis. So the coagulation parameters reveal clearly a PT prolonged value, APTT, which is markedly high, INR more than 6. So what is this? Is this a common clotting factor deficiency or the common pathway factor deficiency, or there are required factor inhibitors? Now, as we know, INR more than 6, it causes a severe bleeding risk in the patient. So what should be done in this scenario, and why this prolonged values are there? So what has happened in this patient? The patient is a cyanotic male with already a congenital heart disease. And this patient, when we saw it, the patient was having a very high hematocrit of 78%. Now, the effect of hematocrit on the appropriate citrate tubes, we have to determine what is this will alter the ratio of blood to anticoagulant because of the high hematocrit, which will look like an underfilling of the tube with less plasma volume and more citrate, which is causing the prolongation of these values, and therefore it will be drastically wrong to give these values in a patient by simply checking the hematocrit. Because the patient has a history of cyanosis and congenital heart disease, we have to take the appropriate blood to anticoagulant ratio. Now, how do we do that? That is, I'll tell you in subsequent tube, but however, we have to use a tuberculin syringe and take out the citrate, excess amount of anticoagulant in the citrate tube in case we find the hematocrit is more than 55%. So by using this formula, we can determine that what should be the appropriate volume of the citrate should remain in the tube, and this should be strictly be taken by a tuberculin syringe so that the vacutainer or the vacuum conditions should not be altered. If it has to be done manually, then manually the tube capping is removed and the anticoagulant taken, and with syringe the sample should be filled and not with the vacuum and the holder. So this will mimic underfilled tubes like I've already told you. So conditions of high hematocrit like neonates, dehydration, burns, polycythemia, high altitude, in all these conditions, the hematocrit should be checked in the patient. Now, specimen transportation and stability. The coagulation samples for hemostasis should always be transported in the ambient temperature and as soon as possible. Again, if you are transporting it cold, that will cause a platelet activation, and platelet function tests have never to be transported in the pneumatic chute because of vibrations which activate the platelet as well as the cold environment which is there in the pneumatic chute. So ideally, all the samples have to be transported within 1 hour of collection, and sample must be capped adequately. For PT INR test, they remain stable up to 24 hours independent of what we are using the processing. However, APTT test must be tested within 4 hours of the specimen collection. So for unfractionated heparin, however, the sample has to be processed within 1 hour because again, the platelets factor 4 which will be released, that will hinder with the estimation of the APTT in these cases. So pneumatic chute, like I've told you, which most hospital labs, they now have pneumatic chutes. The samples are kept in the capsule and they are transported via these chutes to the lab to minimize the time of transportation. However, for certain conditions in hemostasis, particularly the platelet function test, that should not be there because of the effect of vibration, temperature, changes in the speed of the pneumatic chute, and this will cause platelet activation as well as RBC lysis. So this is not recommended for, especially for the platelet function test. So specimen processing, again, a very, very important pre-analytical factors which we have to keep in mind, that the coagulation-based tests, they are usually performed on the platelet poor plasma, except few tests like point of care test, platelet function test, which are done on the platelet-rich plasma. So suppose the sample comes in the lab and the technician keeps it in fridge because the technician is having its own sweet time in processing the sample. But is this recommended? No. Cold storage before centrifugation is not recommended because again, this will cause platelet activation, and there with time, there can be loss of factor VIII and von Willebrand level, which can be misdiagnosed as hemophilia or von Willebrand disease. And suppose you have separated the plasma and kept in deep freezer, freeze thawing, if you are doing it, should be avoided for the samples for lupus anticoagulant because on freeze thawing, the platelets get activated, they release phospholipid, which will again neutralize the presence of lupus anticoagulant, which is an antiphospholipid antibody in the patient. So appropriate centrifugation has to be done when the sample reaches lab. Like I've told you, platelet poor plasma, we should be centrifuge as 1500 gray for 15 minutes. Now for this centrifugation, machines have to be calibrated before you contemplate the process of centrifugation. And high centrifugal forces will again cause platelet activation and RBC lysis. That's why this is the recommended centrifuge speed, which should be given for the hemostasis to make a platelet poor plasma. Now, for certain conditions, we have to ensure that the clearly platelet is less than 10,000. That is double centrifugation we do, particularly for the lupus anticoagulant test. So how do we do this? We take a citrated whole blood, is first centrifuge, the supernatant plasma is aliquoted in another tube, and again repeat centrifugation is done for 10 minutes. So this is important because I have told you like platelets have to be less than 10,000, and the guideline says that you have to maintain this speed and the platelet less than 10,000, and this should always be checked at least 12 times a year or annually. And this can also be done in batches if you are running more number of samples in your lab, because the platelets are rich source of phospholipid. Therefore, any clot-based test, they will lead to interfere and lead to shortening of the PT and APTT, and particularly for the lupus anticoagulant test. So if you have to store the specimen, the separated plasma is usually maintained at room temperature or maybe refrigerated for a few hours without adverse effect. However, if long-term storage is there, the plasma sample centrifuge, and it should be frozen at minus 20 degrees Celsius and used within 2 to 4 weeks of the storage. If it is using at minus 70, it should be stored for 6 months. Now, once we are testing it after freeze thawing, again, the proper thawing has to be done so as to not to cause platelet activation, and the thawing mechanism should be done at 37 degrees Celsius in water bath for at least 5 minutes so as to prevent the cryoprecipitate formation. So there are other interfering factors like we have hemolysis, lipemia, icterus. Now all these will cause particularly interference in the optical base light transmission. So where the presence of the bilirubin, hemolysis and lipemia, the light interference will be there. In those cases, the importance of these variables, interfering factors should be taken into consideration. Though mechanical and electromechanical methods, which some of the automated machines are using, they are usually not affected. And for these, we have to prescribe to the manufacturer guidelines as to how much of the hemoglobin, how much of the bilirubin levels are prescribed, and what is the maximum limit of these factors in your coagulation sample. Excess of bilirubin causes shortening of PT and APTT and increases in fibrinogen and T-dimer. Hemolysis, we know it causes the optical interference as well as releases the RBC contents, and there's a prolongation of values. Therefore, the sample of hemolysis and clotted sample should not be processed even with the mechanical methods. Other variables like we have CRP, which may interfere with APTT depending on the reagent we are using. So just to summarize, what is an ideal sample for hemostasis testing? That is, first is the appropriate test panel, and the appropriate time. Again, I'm stressing for hemostasis, there has to be an appropriate time on the properly identified patient. Atraumatic phlebotomy with minimal tourniquet use, 3.2% trisodium citrate tube, and that should be taken first before any other tube. The volume should be adequately filled, thoroughly mix the sample, transportation within 1 hour, centrifugation within 1 hour so as to maintain the platelet poor plasma less than 10,000, and test plasma if you are aliquoting into the secondary tube. That should be done immediately after centrifugation. So take-home messages. Various analytical errors in hemostasis can be markedly minimized if we take into consideration the pre-analytical variables. And there should be, every lab should have a written guidelines and policy for the blood collection, transport, processing and storage of the coagulation samples. We can have quality indicators right from blood collection to transport, processing, so as to maintain your quality indicators. The ordering the best test which is appropriate for the patient and test panel should be there, correct time point, and incorporate as much as clinical information as possible into the diagnostic approach. And however, since there are many variables which affect the hemostasis test, even if the test has to be done repeatedly for confirmation or follow-up or at a different time point, depending upon the interfering factors and patient variables, we should not hesitate in doing these tests on again a follow-up, particularly in the hemostasis lab. So that's all. Thank you. If there are any questions, you can write in the chat box.
Good morning, Dr. Prerna. This was such a comprehensive talk, all practical points covered.
Thank you,
Very
Dr.
nice. I just wanted to ask you that, are you basically using some bleeding assessment tool at your lab?
We are using ISHBT, BAT score. We have a
Okay.
performer of ISHBT BAT, so we are using that.
Okay. Okay. And what do you do when the pediatric samples are not up to the mark? Do you send them back or you still analyze them and give a rider?
No, if it is still at least 90% fill, volume is there, though the communication with the clinician is beforehand because we are not doing a large number of tests. So the communication, appropriate communication is to them beforehand only. And but however, if we find it is not up to the mark, and particularly for the neonatal sample who are not fasting, like the mother has breastfed the baby in the morning and the sample is lipemic, we have to reject for certain tests. So that is again a big no. Though for neonates and pediatric 1 ml volume tubes are there. However, since most of the centralization in various labs has been done only with the adult vacutainer, so
Right.
we are still using the adult vacutainer tubes for them.
Right.
And if
Hmm.
grossly it is not fulfilling the criteria of pre-analytical, we do reject.
Okay. Thank you so much. Thank you.
Ma'am, few questions there in the chat box. Please see if you can respond.
Dr. Renali, can you please share your screen? And can you please share your
Hello,
screen?
am I audible now?
Yes, ma'am, you are audible.
Okay. I'm just sharing my screen.
Okay, ma'am. Can you please share?
Is my screen visible now?
Yes,
Is
ma'am.
it present?
Yes, ma'am, it's visible.
Okay.
Yes, ma'am. You are.
Okay.
Yes, ma'am. Start, ma'am.
So I'll start now. A very good morning, everyone. I thank all the organizers and uh, my fellow colleagues for making me a part of this meeting. And without much delay, I would just begin with my presentation. And before I begin, I want to just begin with the quote that whatever you begin with the end in mind. That means that you should always know what you are heading towards. And with this thought, I would proceed with the case. This is a case of a 5-year-old child with hematorosis who presented to emergency with large ecchymosis on his left thigh. So on history, he's a known case of severe hemophilia A and had been started on factor 8 concentrates 3 months back. So, what is a likely diagnosis? Is it incomplete factor replacement? Is it development of a platelet function defect? Is it development of inhibitors to factor 8? Or is it development of lupus anticoagulant? So I will not give you the answer right away, but I would like you all to ponder over this question and this scenario in which there is a known case of hemophilia started on factor concentrates, and then there's a kind of breakthrough bleeding which is happening. So with this thought, the topic of my presentation is inhibitors in hemophilia. And what are inhibitors? Inhibitors are IgG alloantibodies to exogenous clotting factors, factor 8 and factor 9. That means the inhibitors won't develop in hemophilias just like that unless we are giving exogenous concentrates which are given as a factor replacement, and they neutralize the function of infused clotting factor concentrates. So whatever factor concentrates you are giving will not be of any help if the inhibitors develop. So they are secondary to the factor 8 and factor 9 products with which they are treated, and they interfere with the function. So basically they are anti-drug antibodies. So why do they develop? They occur as a natural process like for any antibody. Why does any antibody develop? And any antibody develops because it identifies an antigen as foreign and produces a natural response to that. So something like that also happens in hemophilia. The immune system does not recognize the normal clotting factors used for the treatment. This is basically because the individual does not have its own clotting factor. So that indirectly also means that incidence of these inhibitors is much more in severe hemophiliacs in which they have less than 1% of factor which is there, or the factor which is produced is only structurally abnormal. So body, whatever normal protein we are giving is recognized as foreign. So when we talk about inhibitors, the most important inhibitors which we encounter are inhibitors to factor 8. And as you can see here, factor 8 is a big molecule, and most of the inhibitors which develop are towards this A2 domain, C1 domain, and C2 domain. And these inhibitors, depending on the mutations and on the various kinetics, are of two types, that is type 1 kinetics and type 2 kinetics. So what is type 1 kinetics? It is like linear dose dependent variation in the activity and the incubation time, and type 2 is not no is has a complex kinetics and is not exactly dose dependent. So approximately 30% people who are previously untreated develop factor 8 inhibitors, and of those 79% within first 20 exposures and 21% within the first 75 exposures. So this is the incidence of development of factor 8 inhibitors. So when we talk about exposure, what do we mean by exposure? Exposure is defined as any 24-hour period in which factor 8 or factor 9 containing products is given. That means the individual is exposed to the antigen in form of the factor replacement therapy. So what are the potential risks for inhibitors? The risk factors depend on the ethnicity, race, family history, genotype, severity of hemophilia, then what kind of factor replacement we are giving, and what is the intensity of factor replacement therapy we are giving. And I'll mention and talk about this in a slightly greater detail now. So when we talk about the genetic factors, so there are certain mutations which are null mutations. That means they are not producing any factor 8 product. They are large lesions, nonsense mutations, and intron 22 inversion. So they are at the highest risk of development of inhibitors. Then family history of inhibitors, which indirectly also means that the individual is carrying a polymorphism which is prone to development of inhibitors. Then the ethnicity, and then various MHC molecules which we inherit in the polymorphisms of cytokine which predispose us to development of antibodies. And of course, there are some environmental risk factors, like the first exposure to factor 8 is a surgical procedure or a very high frequency treatment, and some other things like early prophylaxis, which is still controversial, and whether plasma derived or recombinant factor, which one of them is predisposing to more development of inhibitors. Similarly, factor 9 also develops inhibitors, and the rationale is the same, but the incidence of generation of inhibitors is less in factor 9. But when they develop, it has a more serious, it is considered as one of the most serious complications, because these inhibitors are associated with a very high risk of anaphylaxis and development of nephrotic syndrome. Otherwise, the risk factors continue to be the same. The only saving grace is that as compared to factor 8, it is less immunogenic because it has homology to various other factors. So, body is able to identify some aspect of factor 9 and therefore not consider it as foreign. And also, it is because it's a smaller molecule. So when we talk about inhibitors, there are various kinds of inhibitors. So it can basic inhibitors. When I say inhibitors, I mean antibodies to the factor replacement therapy. So they can be neutralizing antibodies or non-neutralizing antibodies. So when I say neutralizing antibodies, I mean that they are blocking or neutralizing the action or the clotting factors which we are giving, and by combining with the antibody, with the antigen, they are removing it from the circulation and not making it available for any action. Non-neutralizing antibodies are those antibodies which are in response to these, but they do not interfere with the clotting factor function. So in other words, it is also the antibodies which are present which are not clinically relevant. And in this context, one more thing we need to know is about acquired hemophilia. Acquired hemophilia is a part of autoimmune response which develops in older individuals secondary to some other autoimmune condition. And in this, you will see a old person or a middle-aged person presenting with hemophilia-like symptoms, but there is no past history of hemophilia. So clinically significant inhibitors, we'll talk in a little greater detail. So clinically significant inhibitors are the neutralizing antibodies as I just discussed, and they can be persistent or transient. So that is another issue which we need to know, that not always when you get inhibitors will they be there for life. They can disappear spontaneously within 6 months, and that is what is the definition of transient inhibitors. That means they may be clinically significant, but they will disappear spontaneously within 6 months. So if you have detected an inhibitor, then it's also wise to see and follow up the patient for next 6 months to see how the inhibitor is behaving. The other aspect about inhibitors is the amenistic response to factor infusion. That means that you give the first dose of factor infusion, it may not incite a very bad response, but the very next dose or subsequent doses will invite a very grave response, and you would have to start off with bypassing factor 8 bypassing therapy to achieve hemostasis. Factor 8 inhibitors may be causing anaphylactic response more commonly compared to the factor 8 inhibitors. So these inhibitors, these are IgG antibodies. They are polyclonal because they are in response to an antigen. They can be of many types, but the type which is clinically significant is the IgG4 subclass, which is clinically significant. IgG1 is also present, but they are basically the non-functional inhibitors. The other very peculiar thing about factor 8 inhibitors is that they are time and temperature dependent. So this characteristic we utilize to identify them in the lab, because when we do mixing studies and we see that there is no prolongation of APTT, and after incubation for 2 hours at 37 degree we see and repeat APTT and it comes out to be prolonged. So this is a very, very sure sign that we are dealing with a factor 8 inhibitor. And most of the tests which use factor 8 inhibitors utilize this characteristic of them. The other thing about factor inhibitors is that it's just not enough to know that the inhibitors are present or not present. So we need to quantitate them, and quantities less than 5 Bethesda unit are low responding inhibitors. They're mostly transient, and more than 5 are high responding inhibitors, which may be persistent or which may be, or it may be transient. And then the other characteristic feature is that when we give another dose, there is an amenistic response. So uh, it is recommended that treatment be based on whether the inhibitor is low responding or high responding. So for low responding, we just need to step up the dose. But for high responding, we need to look for alternate methods or bypass therapy. And also for monitoring, low responders can just be monitored by factor 8 activity, whereas high responders by thromboelastography, which is not available in most of the circumstances. So still I'm not sure how people actually would be doing it, because it's slightly difficult to do that. So, having said all that, we as lab people should know what we should be knowing about what is important for us to know as the inhibitor characteristics. So, as for any lab test, there is false positive, there are false negative. False positive meaning that the inhibitor is detected, but clinically it is insignificant. So that time we should know that okay, we are dealing with a functionally inactive inhibitor. Similarly, false negative maybe that the patient is clinically looking like an inhibitor, but lab tests are coming out as negative. So one reason could also be that the immune complexes are filtered from the body, and therefore they're not even detectable by in vitro tests. And also there can be some steric inhibitor interference. The other lab modification in this case, then, if we get a negative, false negative, is that we should do a heating or a acidification to increase the test sensitivity. And I'll be talking about it in a slightly greater detail in a while. But as of now, we have false positive and we have false negative tests which are there, and both are clinically relevant. So indications for inhibitor testing. So normally inhibitors are detected in routine screening for hemophiliacs, or when hemophiliacs are not responding to the conventional standard dose of replacement therapy. So, when do we do inhibitor testing? After the initial factor exposure, after intensive factor exposure, before surgery, before for recurrent bleeds and bleeds, when the factor therapy is not sufficient, and when there is a expected factor recovery or half life which is less than what is expected, and also post operative response to factor replacement therapy. So when do we test? There are two situations which we should be knowing, is that a newly diagnosed hemophilia should be tested every 6 to 12 months, and then annually when the factor concentrates are started. This is because there is a highest chance of developing factor 8 inhibitors in the early part of treatment than later, and therefore it is good to pick it early and treat it early so that we have less severe manifestations eventually. So recommendation is that the patient with hemophilia A or B who receive clotting factor concentrates for more than 5 consecutive days, uh, inhibitor screening should be done within 4 weeks of last infusion. Also, patients who inhibitor screening is suggested pre-operatively in order to determine if an inhibitor is present and may require non-factor 8 containing therapy. So what is the timing of sample? Timing of, especially when there is a prophylaxis and you need to wash out the effect of concentrate which you have given, it should be at 48 hours after giving the treatment. And if the screen is negative, then you know that there are no inhibitors which are present. And the other thing is to also remove the effect of concentrate. You should do a heat and an acid treatment before doing the standard assays for inhibitors. So coming to the main issue, that is how do we measure? So like any coagulation test, we have clot-based functional assays, chromogenic functional assays, and antigen detecting assays. The same is here. So clot-based functional assays have undergone modification, and currently we are using CDC modified NBA, but Bethesda assay and Nijman Bethesda assays have been used traditionally for detection of inhibitors which are present. So the principle of Bethesda assay is that first of all, one Bethesda unit is the amount of inhibitor that will neutralize 50% of 1 unit of factor VIII concentrate in normal plasma after 2 hours of incubation at 37 weeks. That means if we know the concentration of factor VIII in normal plasma, so if and therefore the APTT should be normal in that case. So once we give 1 unit inhibitor, Bethesda inhibitor in that, it should prolong the APTT. So that is the definition of Bethesda unit. So exogenous factor VIII is added to plasma, mixture is incubated, and factor VIII is progressively neutralized, and then we measure the residual factor VIII activity. So this is a diagram just to show that we have a diluted patient plasma, plasma, a pooled normal plasma, and we make a mix of it, incubate for 2 hours, and measure the residual factor activity. And then there is a control also for in which we, instead of patient plasma, put a buffer inside. And then the residual factor activity is measured. And we double the dilution, and low inhibitor titers can result in false positivity. Nijman Niemann modification of Bethesda assay. Just a sec. The Nijman modification of Bethesda assay, in which we, instead of buffered uh, plasma, we add a factor deficient plasma, and we then measure the residual factor activity. Then the CDC modification, we use a preheated patient plasma for, and we heat it at 56 degree for 30 minutes, and then do the repeat APTT after preparing a mix at 2 hours. And that is how we are able to find the residual activity, and that is an indicator for the presence of inhibitors. So residual factor activity is the key to measurement of inhibitors. So this is a plot which shows that how we plot it. So here we have a x-axis in which is a logarithmic scale, and this is the y-axis, x-axis, which is the linear scale, and the y-axis is a logarithmic scale, where we have the residual factor activity after 2 hours of mix, and then we plot it against the standard line which we have made in the laboratory and calculate the Bethesda units. So this standard line can be prepared by this calculation, in which 2 minus log percentage of residual activity divided by 0.0301 is the formula which is used for calculation of Bethesda. So, if the residual activity is more than 100%, then the Bethesda unit is zero. But if it is a bit less than, more than 75%, then we dilute it and measure. If it is less than 75%, then we do a serial dilution till more than 25% is achieved. For example, if the residual activity is 10%, so we keep diluting till the time the residual activity is between 25 to 75%, and then we do the calculation with this and multiply by the dilution factor. For example, we in a test, the residual activity is 50%, and it was achieved at a dilution of 1:10, and then we multiply it with this dilution and we get the Bethesda titer. So the limitations of clot-based assays is the same for any clot-based assays, like there can be a drug contamination and they're less accurate for type 2 inhibitors. Chromogenic assays are are better because they have a fixed endpoint which is more clear, because we have chromogens which identify factor 10A development, but they are expensive. Then we have the third technique, which is the antibody detection assay, which are immuno-based assays like ELISA. The problem with it is that it measures both inhibitory and non-inhibitory antibodies, but they are a very good, useful screen and a cheaper one. So the definition of positive inhibitors is Bethesda more than zero point 0.6 is for factor 8 is positive, and more than 0.3 for factor 9 is considered positive. And the point is, the most important point to remember here is that whenever we are getting these values of inhibitor, we also need to know the laboratory response to the treatment. And the guidelines say that less than 66% recovery of factor 10 to 15 minutes after infusion is a clinically significant inhibitor. So both these things have to be interpreted together when we say inhibitors are positive in a patient. So confirm, the take home message here is that we need to confirm an inhibitor by repeat laboratory testing and also follow it for more than 6 months, and documenting a poor factor recovery and shortened T half of less than 6 hours in hemophilia A and 9 hours in hemophilia B. So coming to the final slides, the approach to laboratory diagnosis is very simple, that we need to do a screening test for inhibitors, in which we need to have a normal plasma, test plasma, incubated mix and an immediate mix. And if we have a prolongation in both immediate and an incubated mix, that it's an immediate inhibitor. And if it is prolonged only in the incubated mix, then we have a time dependent inhibitor, which is a factor 8 inhibitor. And when we have this positive, then we have a choice of assays to do. So if we have a large setup, then we can do an antibody antigen detection assay. And if it comes out to be positive, then you can do a Bethesda assay for quantitation. But if it is a very small laboratory in which you get 1 or 2 samples in a week, then we can directly proceed to a Bethesda assay. And for most of the known inhibitors, you can use a classic Bethesda assay, because where high titers are expected. In low titers, NBA is recommended, and patients on prophylaxis CDC NBA modification is recommended. So with this in mind, it brings me to the end of my talk, and I would be happy to answer any question. But before I end, I would just like to say that inhibitor detection is a very tricky thing. And as my previous speaker, Dr. Prerna said, there are so many pre-analytical variables there. And when you get an inhibitor positive, it is also always to be double checked and also correlated clinically. And then just positive is not enough. We also need to titrate it and give the quantification, because that is how we'll be able to prognosticate. Thank you.
Thank you, Dr. Mrinalini. It was a very used to talk about inhibitors. Uh, what are the, I was just wanting to ask, what are the pre-analytical variables specifically to be taken care of?
Okay, so first of all, we need to know that whether the patient is on any kind of drugs during that time. And like clotting, you if there's a heparin contamination, or if it is from an IV line side, then the clot based assays will not give a good result. And again, the same thing, that the draw of sample, there should be no frothing, it should be a smooth puncture, because it's all a APTT based test. So any pre-analytics which is involved in APTT is going to affect the interpretation of Bethesda assay. The other thing is that antigen antibody tests may not require much stringent pre-analyticals, but interpretation with the clinical parameters is important. We should know that patient is actually having clinical presentation of inhibitors in that case. Otherwise, we may be giving non-clinically significant inhibitors as inhibitor positive.
Okay, thank you.
And for any further questions, you can reply on the chat, please. And we are going to the forward. Dr. Sabina, can you please share your screen?
It says host disabled screen sharing.
Yes, ma'am. Wait a minute. Now, ma'am, can you please share?
Yes.
Yes, ma'am. Start now.
Can I start now?
Yes, ma'am.
Okay. So I'm Dr. Sabina Langa, Senior Consultant, Department of Hematology, Sir Gangaram Hospital. Today I'll be discussing bleeding disorder case-based discussion. In today's talk, I will be covering some basics of coagulation and algorithm approach to bleeding disorders, and interesting case studies on common bleeding disorders, rare and some acquired bleeding disorders, especially those admitted in the hospitals. So hemostasis, as we all are familiar, is primary and secondary hemostasis. A vascular injury exposes the collagen, which binds the platelets. Vasoconstriction takes place. Platelets release clotting factors and initiate platelet aggregation. Clotting factors activate thrombin and coagulation cascade begins. Then thrombin activates fibrin stand and activates platelets to form a platelet plug. So we are all familiar with the coagulation pathways, which were initially classically divided into intrinsic and extrinsic, which we now know starts with the tissue factor and 7A to activate factor 7. And it all merges and activated factor 10, which converts prothrombin to thrombin. One molecule of factor 10A can form 1,000 molecules of thrombin. which acts on fibrinogen to form fibrin strands and which are further strengthened by activated factor 13. So this brief overview of factor of coagulation. I will now like to put light on the diagnostic algorithms that we follow in our laboratory for any bleeding disorders. So it is very essential to have an algorithm in order to economize the resources and to quickly come to the correct diagnosis. So the diagnostic algorithm starts with the history and physical examination, screening tests or first line tests, and finally the definitive advanced testing. Most important bleeding disorders is detailed history taking, which should include site or sites of bleeding, age of onset, type and frequency of bleeding, whether provoked or unprovoked, precipitating factors, drug history, anticoags, NSAIDs, antiplatelets, any associated symptoms, how is the bleeding controlled, was hospitalization required, and family history also gives a clue to the diagnosis. Examination should include to look for mucocutaneous musculoskeletal bleed, pallor, jaundice, organomegaly, wet purpura. At times, the patient comes to us with asymptomatic elevated APTT or PT, usually diagnosed before the surgery. If we take a detailed family history, we would be able to also pinpoint whether the inherited cause is X-linked autosomal dominant. A male pattern of inheritance with female heterozygous gives us an indication for X-linked. When male and females are both seeming to be involved and it seems that a parent is giving to the child, it is likely to be an autosomal dominant. A negative family history is seen in autosomal recessive with history of first or second level consanguinity, novel or sporadic mutations, and acquired disorders. As we are familiar, there are two types of clinical bleeds, which is platelet type and hemophilia type. The platelet types have oral mucocutaneous bleeds from gums, epistaxis, petechiae, prolonged bleeding from cuts, bleeding which is relieved on applying pressure. Hemophilia type of the deep bleeds in muscles and joints, localized hematoma. They are delayed in onset and not relieved on applying pressure. If symptoms are mild or moderate, then we can use standardized bleeding assessment tool by ISTH. In fact, it is essential that clinically we should give a PAT score to a bleeding patient. So this BAT instrument has 14 parameters, 14 clinical symptoms, and it has 5 scores. The highest being given to a history of blood transfusion or replacement therapy. It includes epistaxis, cutaneous bleeds, bleeding from minor wounds, oral cavity, GI bleed, hematuria, tooth extraction surgery, menorrhagia, postpartum hemorrhage, muscle hematoma, hemarthrosis, CNS bleeds. So a score of greater than 4 in adult males, greater than 6 in adult females, and greater than 3 in children is positive for a bleeding disorder. Now that we have established a bleeding disorder, we do first a screening coagulogram, which in our laboratory, we start with CBC DLC peripheral blood, which will give us a fair idea of the platelet counts, morphology, prothrombin time, exhibiting extrinsic pathway, APTT for intrinsic, thrombin time, fibrinogen D-dimer, and also mixing studies. After analyzing the first line screening test only, then we advance to the next advanced test. I can give you an example here. For example, here the PT and APTT are prolonged, whereas platelet count and TT is normal. So this could be an acquired deficiency of vitamin K, patient could be on oral anticoagulants, or this could be a deficiency in the common pathway. The detailed history taken again for antibiotics use, which can affect the normal bacterial flora, any anticoagulants is required. Or then we can also go to analyze for the common pathway defects. Similarly, if the APTT is prolonged, we need to do mixing studies, and it could be because of anticoagulants or factor deficiency. What I want to pay attention is in our being a multi-speciality hospital, we have a lot of bleeding disorders which is found in in-house patients which are admitted. So in these patients, like as you can see, there are multiple defects, low platelet count, PT and APTT. This could be in a liver disease, massive transfusion, acute liver disease, DIC. And as in the last case, prolonged PT, APTT, and TT, which could be because of fibrinogen deficiency, liver disease, heparin, or hyperfibrinolysis, in which a point of care testing, ROTAM, has been found to be most useful. So coming to the first case, she is a 21-year-old female referred with history of epistaxis, which was controlled by applying pressure. Petechiae were present on her extremities, and there was menorrhagia with history of passing clots. She was given treatment with tranexamic acid and promolate N, and her BAT score was 8. APTT 48 seconds, PT was normal, and mixing studies revealed correction of 84.65%. So with the given history and with the correction studies, we went on to do a von Willebrand disease panel. So in the von Willebrand disease panel, we include factor 8 levels, von Willebrand factor antigen, ristostatin cofactor assay, and ristostatin cofactor by von Willebrand factor antigen ratio. As you can see, the factor 8 levels were low. Von Willebrand factor antigen was less than 1%, only 0.3%, and correspondingly ristostatin cofactor and the ratio was reduced. So with less than 1% von Willebrand factor antigen, we diagnosed it as von Willebrand disease type 3. Coming to a word about von Willebrand disease is the most common mucocutaneous inherited bleeding disorder described by Eric von Willebrand in 1926. It is autosomal dominant inheritance. It can have structural or quantitative defects and it impairs the binary hemostasis. The gene is located on chromosome 12. Von Willebrand factor is secreted by endothelial cells stored in weevil pallid bodies by megakaryocytes and stored in alpha granules. This is the ISTH 2006 classification of von Willebrand disease, which includes type 1, type 2, type 3, pseudotype von Willebrand disease, type 1C von Willebrand disease, and acquired von Willebrand disease. Most of them are autosomal dominant, except type 2N and type 3, which are autosomal recessive. Pseudotype von Willebrand disease is gain of function mutation in platelet GP1B alpha gene with increased affinity for von Willebrand factor. Type C von Willebrand disease is associated with increased clearance of von Willebrand factor from the plasma. So there is partial deficiency in type 1, qualitative defects in type 2, and almost complete deficiency in von Willebrand factor. I will discuss further about the subtypes of 2 after the next case. So, okay, in here only you can see that in type 2A, there is decreased platelet binding and loss of high molecular weight antigen. Type 2, there is severe factor VIII deficiency because of decreased factor VIII binding and it almost simulates hemophilia. Type 2B, increased platelet binding, you can see platelet aggregates, the REPA is positive. And in type 2M, decreased platelet binding and normal multimers are formed. So importantly, when we do a von Willebrand disease panel, what we have to know is whether the ratio were discordant or concordant. A discordant ratio is consistent with type 2 von Willebrand disease. A ratio of ristostatin cofactor by von Willebrand factor antigen more than 0.7 in our by our kit is concordant and less than 0.7 is discordant. Similarly, ratio of factor A to von Willebrand factor antigen less than 0.7 is discordant and it can help us to differentiate von Willebrand disease type 2N from hemophilia. One important take-home message is in case of mild to moderate hemophilia A, it is important that you should do a complete von Willebrand panel to rule out von Willebrand disease. Coming to the next case, she is a 30-year-old female, history of dental extraction followed by oozing from the site of and on for 1 month, history of menorrhagia and bad score 7. Family history with similar complaints in mother, APTT is prolonged, the rest of the parameters are normal. So the mixing studies showed more than 75% correction. Her von Willebrand disease panel showed mildly reduced von Willebrand factor antigen, reduced factor 8, reduced ristostatin cofactor, and the ratio more than 1.92. So as explained earlier, it is a concordant ratio. So this is a von Willebrand disease type 1. Coming to the next case, 17-year-old female, second-born child of her parents, no bleeding history in her elder brother, no history of consanguinity, epistaxis off and on. She attained menarche at 13 years and has heavy menstrual bleed. Her APTT is elevated and her von Willebrand panel shows reduced factor 8 von Willebrand factor antigen, ristostatin cofactor assay is reduced. The ristostatin cofactor to von Willebrand factor antigen is 0.35, giving us a discordant ratio, which is now consistent with von Willebrand disease type 2. So one of the tests that we do further to subclassify is REPA. In REPA, that is ristostatin-induced platelet aggregation, which is conducted on a luminoaggregometry, the type 2 disease will show increased aggregation with ristostatin 0.25, which is reduced ristostatin. A normal patient will show no aggregation with low volume ristostatin. So as in this case, this has showing a increased aggregation suggestive of type 2 von Willebrand disease. Next case is a 3-year-old female, firstborn child, history of consanguinity in parents, history of epistaxis and gum bleeds, received 1 unit blood transfusion, history of purpuric ecchymosis, excessive bleeding from cuts. no siblings, no family history of similar problems, no umbilical stump bleeding. The screening coagulogram, as you can see, is essentially normal. So if you have a normal screening coagulogram, what comes in our mind is either a factor 13, but we did not have any significant factor 13 like bleed, or platelet function tests. Or next we proceed to the platelet function test. Sometimes the von Willebrand disease panels also show, von Willebrand disease can also show normal first line tests. So the factor assays values were like this. They were essentially all normal. And so what next? What next is that we decided to do platelet function tests using luminoaggregometry. After in our laboratory, we usually do this test on appointment, where we ask the control and the patient to come fasting with no use of any alcohol, any drugs, and no history of fever. So these are the graphs of the platelet aggregometer. Here we use 5 agonists like ADP high dose, ADP low dose, collagen, epinephrine, arachidonic acid, histocytin high, and histocytin low. As you can see in the control, all the aggregation is normal. 86% for ADP, 75% for low dose, and collagen, epinephrine, arachidonic acid. Whereas the similar agonists with the patient showed either no, like 0% aggregation, or very minimal aggregation. Summarizing these findings in this graph, we can see in the test, the aggregation with ADP, epinephrine, collagen, arachidonic acid is markedly reduced and moderately reduced with histocytin, whereas that of control in the experiment were normal. So hence we conclude with the given history and with the findings that this patient is likely to be that of a Glanzmann's thromboasthenia. We advise platelet flow cytometry 4161 to look for downregulation and NGS to look for mutations in the integrin alpha 2 beta 3 and ITGA2B and ITGB3 genes. Glanzmann thromboasthenia is a congenital bleeding disorder caused by defect or deficiency of a platelet integrin alpha 2b beta 3. Integrin is the platelet fibrinogen receptor essential to platelet aggregation. Patients with this disorder have lifelong bleeding complications involving mucocutaneous. So one of the way to diagnose the disease is also flow cytometry. As you can see on this graph, the 41 and 61 expression is downregulated on the platelets. Next case is a 3-year-old male child who came with complaints of recurrent ecchymotic patches since 1 year of age. History of epistaxis on and off, bad score 4, only child of his parents, no family history of bleeding, no history of consanguinity in parents. As you can see in the CBC, his platelet counts were slightly low, 85,000, and peripheral smears also showed large platelets. Her PT, APGT, factor 8, von Willebrand were all normal. So hence we proceeded to the platelet aggregation test on light transmission aggregometry on our instrument called chronolog. In here, you can see the control is showing normal aggregation with all the agonists, and the test is also showing normal except for the high dose histostatin. Here, in the high dose histostatin in black, you can see the aggregation is only 5%, and rest of the plots are showing normal aggregation with the rest of the other 5 agonists. To summarize this finding, we have reduced aggregation with 1.25 milligram per ml. But also going back, we also did a repeat aggregation using 1:4 histostatin dilution. So that is diluting the PRP with normal pool plasma. But we still found an aggregation of 5%. So, a markedly reduced aggregation with high-dose histostatin alone is suggestive of von Willebrand disease and Bernard-Solier syndrome. How to differentiate between both these is that you repeat the test with normal pool plasma, which would be having a von Willebrand factor, and it will correct the aggregation. However, in this test, as it was not corrected, and looking at the complete clinical scenario and peripheral picture, we gave a possibility of Bernard-Solier syndrome. However, we advise flow cytometry and NGS studies to confirm the diagnosis. Bernard-Solier syndrome, also known as hemorrhagic Paris thrombolytic dystrophy, is an extremely rare inherited blood clotting disorder caused by giant platelet cells, thrombocytopenia, prolonged bleeding. It involves a defect of GP1B95 complex and genetic mutation involving GP1B alpha, beta, 9, which are 3 of the 4 subunits of GP1B95 complex. It is Clinically, you find bleeding from different sides, epistaxis, cutaneous bleeds, hemorrhage after trauma, prolonged bleeding after dental procedures, heavy menstrual bleed in females, but sometimes it can just limit to unexplained purpura or bruising only. Next case is a 13-year-old boy presented with seizure to neurology department. Imaging study suggestive of intracranial hemorrhage. Basic coagulogram shows elevated PT 172, markedly elevated APTT, normal TT, fibrinogen, and clot solubility tests were all within normal limits. So, looking at this, the common pathway where both the PT and APTT are elevated is suggestive of deficiency of common pathway factors, which could be factor 10 and 5. So, we carried out factor 10 and 5 levels. Factor 10 levels were reduced 0.3%, the normal being 77 to 135, and factor 5 levels were normal. So hence it was a case of factor 10 deficiency. Factor 10 or short power factor was first described in 1950s in US and England on two patients, Rufus Stott and Andre Power. The incidence is estimated in 1 in 5 lakh to 1 in million. It is inherited as autosomal recessive. It needs vitamin K synthesis, which is produced by the liver. Mild factor 10 deficiency can present as easy bruising, nose or mouth bleed, bleeding after trauma. Severe can also present as excessive umbilical cord bleeding, joint bleeds, intramuscular bleeds, intracranial hemorrhage, and menorrhagia in women or first trimester miscarriage or postpartum hemorrhage. Next case is a 5-month-old child presenting with history of intracranial bleed, elder sibling of female child, no positive history on bleeding, born as full-time normal vaginal delivery to parents with second-level consanguineous marriage. No positive family history of bleeding. The initial screening coagulogram was normal. However, the clot solubility test with 5 molar urea and 1% monochloric acid shows absence of clot. The clot had dissolved within 1.5 hours of being put in monochloroacetic acid, suggestive of factor 13 deficiency, and clot dissolved within 3.5 hours of being put in 5 molar urea. Hence, the clot solubility test is suggestive of factor 13 deficiency, and quantitative factor 13 assay was advice. We did factor 13 levels in our hospital, and they were found to be deficient. So the factor levels were 2.7 deficient percent, suggestive of factor 13 deficiency. Factor 13 is made up of two units, factor 13A and B. It helps in clot stabilization by cross-linking the fibrin and platelet-dependent clot retraction in wound healing and tissue repair. Factor 13 deficiency, which is mostly of the factor 13A subunit, is extremely rare and is inherited as an autosomal recessive disorder. It can remember not only present, which is the commonest bleeding presentation is delayed umbilical clot bleeding, present in 80%, but it can also present as recurrent pregnancy loss and or as bruising, hematomas, muscle bleeds, and delayed post-surgical bleeding. So remember, in recurrent pregnancy loss, factor 13 levels are also important to be done because factor 13 and fibrinogen are important in placental stability. Next case. Now, after talking about inherited bleeding disorders at length, let me come to some very interesting cases. More often than not, for patients, more important and more frequent are the patients who are admitted in your hospital and the clinicians complain of bleeding. So here there are scenarios of acquired bleeding. The first case is of a 36-year-old female, gravida 3, para 1, live 1 abortion, and 33 weeks of pregnancy. She is complaining of bleeding per vaginum and bleeding count. Her screening coagulogram shows elevated thrombin time. The upper level is 16 seconds in our laboratory. Low fibrinogen. So one thing I want to emphasize here, the fibrinogen levels which we normally give in an adult male or female is 2 to 4 gram per day. But in a female, which is a high, the fibrinogen baseline fibrinogen levels are higher. So in a female, even a 2 gram pregnant female, fibrinogen level of 2 gram is also low, and it has to be maintained almost up to 3 gram per deciliter. This I will further show with this case. The APT levels are 31.5 seconds, PT 11, platelet 4 lakhs, and D dimer is elevated, TLC is reduced. For this patient, we carried out point of care testing known as ROTEM. And in ROTEM, these are the findings which we got on the extem, on the intem, which were essentially normal except for reduced A10 and A20, which gives the strength of the clot. In the fifth term, again, the A10 and A20 value were reduced to 4 millimeter and 5 millimeter. The MCF, which is determined by the fibrinogen and the platelets, was further reduced. However, FIBDEM uses a reagent which nullifies the effect of platelets, hence reduced MCF on FIBDEM again suggests a severe hypofibrinogenemia. The patient was then advised to give cryoprecipitate and fibrinogen injection, which reverted her findings and her life was saved. So, what is the question now? The question is, in the patients who are admitted and who are also as important or even more severe bleeders than the inherited bleeding disorders, we have a number of agents present to us which we can be given, which includes Trenexa, antifibrinolytics, protamine, FFP, platelets, fibrinogen, PCC. The bleeding is severe and it is acute, and it is very important to make a decision what to give, which is effective, and only an appropriate therapy will stop the bleeding and save the patient. So one of the tests, so as I said, time is life in severe bleeding. So one of the point of care testing that we are using now in our hospital is ROTEM, which is rotational thromboelastometry, and enables to assess viscoelastic profiles of whole blood in various clinical settings. The other form of it, which is also available, is TEC. But we are now gaining more experience on NOTEM, and ROTEM guided bleeding management has become an essential part of patient blood management, which is an important concept in improving patient safety. As the turnaround time of standard laboratory coagulation test is 30 to 90 minutes. In contrast, point of care testing ROTEM provides the first answer within 5 to 10 minutes or 10 to 15 minutes max. It has a number of tests, which is EXTEM. As you know, it will, as the name indicates, it talks about the extrinsic pathway. INTEM, which tells you about the intrinsic pathway. FIBTEM, in which talks about particularly about the fibrinogen as the addition of this reagent called cytokalasin D, which overcomes the effect of platelet and which tells you only the effect of fibrinogen in the clotting. And APTEM, which tells about fibrinolysis, and also there is a heptem. So after talking a brief about ROTEM, let me give you one last example. There is a 60-year-old female with history of acute necrotizing pancreatitis, post-elective laparotomy and pancreatic neck resection. She is diabetic, hypertensive with morbid obesity. She was transfused for FFP, and the patient sample was sent to us, which is sent in citrate, to know how her coagulation status is. Her PT was elevated, INR 5.7, APGT normal, fibrinogen 3.24, D-dimer 2. Then we carried out ROTEM. As you can see by these arrows, that most of the tests in the INTEM are normal, and A10, A20 and MCF are in fact increased. In the FIBTEM, again, the A10, most of the tests are normal with increase in A10, A20 and A30 and MCF. In the extem, however, as you can see, this is a typical fish mouth appearance, and there is increased lysis. The ML, if you can see, the ML is increased to 76%, the highest being only 15%. Now, what does this indicate? This indicates hyperfibrinolysis in the patient. Hyperfibrinolysis. So, to summarize this case, a case of acute necrotizing pancreatitis, diabetes, hypertension, morbid obesity, with 4 units FFP given with elevated PT, normal fibrinogen, INTEM, EXTEM and FIBTEM findings altogether suggesting of hyperfibrinolysis and mild deficiency in extrinsic pathway, we advise tranexamic acid and FFP. So this is an example where point of care testing and global assays are now put in use to help save the patients who are bleeding in your hospital. Thank you. That is the last phase of my presentation. Thank you, and I'm ready for any question and answers.
Ma'am, you have a question in the chat box.
I think I can only read one question. Can you please explain pseudotype and type C von Willebrand disease? Is that the question?
Yes, ma'am.
So in the pseudotype, the defect lies in the platelet. So platelet has the most important interaction of the von Willebrand is with the platelets, and the mutation is actually in the platelet rather than the von Willebrand, and the final diagnosis is only made on molecular studies. In type C, there is increased clearance as in the 2021 guidelines. The way to test type C is after giving a dose of desmopressin, then you look for the levels of von Willebrand disease. And so this is one of the newest subtype that is being added to the von Willebrand disease. But I do not have any case to show you. Any more questions?
For any further question, you can reply or answer in the chat box. We are moving forward.
Okay, if there are any, because I can only see one question here.
Yes, ma'am. There is only one question right now.
Hmm.
Can we proceed with the next talk?
And can you please share your screen?
Yeah. Is the screen visible?
Yes, ma'am.
Okay. So should I start?
Yes, ma'am.
Okay. Thank you. At the outset, I would like to thank the organizers for empaneling in this 1 week long diagnostic conference. And it has been a wonderful experience. And since morning, we have been listening to different talks related to the coagulation disorders and things. So I'll be talking about how to actually set up a coagulation lab. This would include things from my own experience and some guidelines and recommendations which are available as to how to evaluate the equipment and how to validate and verify that what you are performing in a lab is of a good standard quality. So when we think of a coagulation lab in patient care, I would say that it has a very important role in hemostasis assessment, the screening, the diagnosis of bleeding disorders, assessment of coagulopathies, and then thrombophilia workup. And a number of area of tests which come to our mind when we think about a coagulation lab. The basic ones being the basic screening tests like the PT, APTT, thrombin time, plasma fibrinogen, mixing studies. Then we go on and do confirmatory assays like factor assays, inhibitor assays, and platelet function testing. And then we have other advanced analyzers now, which have actually revolutionized the diagnosis of many bleeding disorders and helped us to diagnose such cases. And there's also these global tests in hemostasis, which give us a total profile of the what is happening in vivo. So setting up a coagulation lab, where to start? As being in a government setup, we have understood that जब भी कोई setup करना होता है, तो we divide our requirement to two headings. First is the manpower, and then comes the infrastructure. So when we talk about manpower, when we are thinking about a coagulation lab, we really need to have good dedicated and trained personnel who will be taking care of the samples which will be received in the lab. Maybe when you are starting the lab, you might not really have, trained personnel, but before he starts handling the samples, it is very important that he has a basic knowledge about the handling of a coagulation sample, the pre-analytical variables, the analytical variables, and how to go about and interpret a prolonged result or a abnormal result. So I would say a minimum of a 2-member team is required for carrying out coagulation assays. You need to have a doctor naturally, and then you need to have a trained technician, may it be a manual setup or it be an automated setup. These are basically the backbones of the lab who ensure that the lab is performing good quality tests and the results are being interpreted properly. Second, we need is a good infrastructure. There are some basic equipments without which nobody can actually establish a coagulation lab. And then if you have funds and either in a private or a government setup, you can go ahead and plan which analyzer which can be procured for the lab. So before you actually go on to decide what analyzer has to be procured for the lab, you need to first assess what is your lab or your institute or your demand of the clinician. What is the workload? What are the type of investigations which you are planning to do in that lab? And that will help you to define as to which setup would you like to go ahead and execute, so that you are able to maintain the turnaround time, you are able to maintain the lab standards, and also cater to the needs of the clinician. I personally believe that the lab work is driven largely by what your clinician is asking for. आप बहुत बड़ा सेटअप कर लो और आपसे कोई वो टेस्ट मांग ही नहीं रहा, तो उसका कोई फायदा नहीं है. So eventually you end up deciding what kind of a patient load you have, what is your draining clinical side asking from you. That helps you to take a call as to what kind of a setup do you need to have in your center. So irrespective of what kind of a center you need to go, Dr. Prerna has beautifully explained all the pre-analytical variables which are important in coagulation testing. And either you go for manual lab setup or a semi-automated or an automated, this still forms one of the major cornerstones or the crux of the of any coagulation lab, to ensure that whatever output your lab is giving is being addressed properly. And in the pre-analytical variables, if you see the 3 broad categories which they have divided is the specimen collection, the transportation, and subsequently the processing and storage. So ma'am has already highlighted what is the importance of patient identity, the age, the history of the patient from which the sample has been collected. Was it a pediatric age? Was it an adult? Is there any drug history? Are there any other factors which are interfering with what would be the lab results? So a person who's sitting in the lab should be given all these information before he starts processing the samples. The sample collection, there are a number of guidelines which are saying what is the order of draw, what is the needle size which should be there, the anticoagulant ratio, and ma'am has also highlighted how 3 to 6 times we need to gently mix. And if in patients who have a high hematocrit, the volume needs to be addressed. Subsequently, I feel this is another very, very important part. If you are a lab, a standalone lab, which is receiving samples from outside, you really need to address this issue that the samples which are transported to your lab are, in a proper temperature, because any elevated temperature would lead to degradation of the factors and unnecessarily prolong or result in abnormal test results. All APTT assays should preferably be performed within 4 hours of sample collection. All PT assays can be done within 24 hours because the PT results are more stable. But you should avoid storing these samples in cold, because factor 7 gets activated. And any kind of a traumatic sample should probably be listed in your repeat sample or a discard a criteria for rejection of the sample. Though there are you can assess that what is the degree of hemolysis, and mechanical based detection systems में hemolysis का interference कम होता है, but it is best to have a repeat samples if you feel that the sample which you have received in the lab is not of good quality. And again, irrespective of whether you go for a manual setup, a semi-automated or a fully automated setup, there are some things which any lab would require, that is a centrifuge. So a refrigerated centrifuge is not mandatory. You need to have a good quality centrifuge. You need to separate your plasma. Then you need to have your pipettes, the basic glass tubes, plastic tubes, your cuvettes, sample, then you have to have a water bath. Because if either a manual setup, you would need a water bath. If you are doing an automation, then also for thawing your reagents, you would use that. You need a stopwatch, table lamp when you are doing a manual tilt tube method. Then you need to have a refrigerator, a deep freezer, because you might not be doing sometimes all the tests together at once. And for some of the tests, you will have to stock away the plasma at least -20 or -80, depending upon how long you plan to store the samples. So this is some basic infrastructure. A person who is actually involved in the procuring and setting up of a lab would understand how important these equipments are before you actually move on to a real coagulation, thinking about the real analyzer which has to be procured. So again, coming to the testing, so you can have a manual testing. There'll still be many peripheral labs which do not have the funds for semi-automated or a fully automated analyzers, and I would say their manual testing is still good to go. Then depending upon your budget and sample load, you can go ahead for automation. So as I said, in a low resource setting, when you do plan for a manual setup, let us see what all investigations can still be performed by a manual setup. You can evaluate a patient with a primary hemostatic defect. You can evaluate for secondary hemostatic defect. You can work up patients for DIC if there's an ICU in your lab, in your center. So when we are evaluating patient for primary hemostatic defect, bleeding time still is a good, sensitive, simple test which does not require any major infrastructure. This is the photographs which are clicked by Dr. Dinesh and beautifully highlight how this method is being executed. Naturally, these results have to be interpreted in light of the clinical history. Though unfortunately, bleeding time has its own limitations, but in a patient with suspected primary hemostatic defect, it still forms an important screening tool. And I would say that in a recent survey which we carried out just to ascertain how many centers are still using bleeding time, all out of 45, I would say there were 30 centers which were still using bleeding time, and with an equal distribution in the government as well as the private labs. So the simple test is still there to stay, and for people who do not have a more advanced setup for a platelet function testing, this might be an important tool. Second, to assess the primary hemostasis, another test which can be taken care of which can take care of this part is the clot retraction test. This is a simple and reproducible test which can be used to assess platelet function. Frankly, we are not doing this test in our lab because we do have a platelet function testing by light transmission aggregometry and even supported by flow cytometry. But I'm just bringing out these things so that people, who are at peripheral centers should not think that since we do not have an analyzer, there is nothing we can do. There's actually a whole lot of investigations which can be done. If you are really dedicated and keen on, a coagulophilic person, then you would actually go ahead and standardize these tests in your lab, and they can be a really value-added addition to the existing armamentarium in the lab to work up a patient with a bleeding diathesis. So like here, these tubes demonstrate where there is a normal clot formation, and here the clot is not formed properly. So this could be either due to a defect in the platelet, or it could also be due to a defect in the fibrinogen or coagulation factor levels. But if there is a defect in coagulation factor levels or fibrinogen, then naturally your manual PT and APTT will also be prolonged. So that will also help to exclude that largely is this a platelet driven defect, or is this due to a deficiency of the coagulation factors, because this test is largely dependent upon the interaction of the platelets and the fibrinogen and the subsequent fibrin mesh formation. So this clot retraction test, if you look up literature, you will still get articles which are talking about clot retraction test, how it can be standardized, how you can weigh down this clot at the end of the test and use it reproducibly for, as a screening tool for primary hemostatic defect. Then when we talk about the secondary hemostatic defect, you can start working up for evaluating the extrinsic pathway by doing a manual PT, where we use thromboplastin in our routine is a reagent which is used in the lab. You can go ahead and do manual APTT. Again, for this, you need not have any dedicated analyzers. All you need is your samples, your centrifuge, after which you have separated your plasma. You need your APTT reagent and your water bath, stopwatch, and you are good to go. if you have standardized this technique in your lab, you are good to go to interpret the patient samples. So you can do PT, APTT, thrombin time, fibrinogen. Probably I would say, I am not sure, but it will be a good idea to do manually. So this will otherwise help you to at least identify that whether or not there is an inherited deficiency of the coagulation factors, or they could be, in patients with liver disorders, it could be acquired deficiency. If these are prolonged and you want to go ahead and do mixing studies, again, you do not need any automated analyzer for that. And further, even for specific factor assays, we have seen that if you are doing manual factor assay, even using one stage APTT clot based assay, that is also helping you to identify the factor level. So all this can be taken care of manually. And this is just an example of how a manual factor rate assay is being done, where we make this is example of the mixing study, where when your PT or APTT is abnormally prolonged, you can use a pool normal plasma, mix it, because a pool normal plasma will provide 50% of the factor levels and help to correct your prolonged APTT or PT, and that will help you to identify whether there is a factor deficiency or is there a inhibitor. There are many reagents which can be used, which will help you to narrow down which factor it is. You can use aged serum, or you can use adsorbed plasma. Again, both of these do not require any dedicated equipment which will help you to prepare. Aged serum is something which is obtained from any biochemistry lab after 48 hours. You just leave the sample standing, let it rest for 48 hours, and you can use that as aged serum. And then adsorbed plasma can be prepared by mixing pool normal plasma with barium sulfate. You can also go ahead and procure commercially deficient plasmas to narrow down which factor is deficient if your APTT is prolonged. So that gives you a fair idea that what coagulation defect are you dealing with in a given clinical setting and a relevant history. So once you have determined that there is a factor deficiency, then we have clot-based assays and also chromogenic. So naturally, doing a chromogenic assay manually is not possible, but a clot-based assay is possible. And in a clot-based assay, usually what we do is we prepare serial dilutions of the test plasma as well as standard. Subsequently, we put APTT, and on a double log curve, we are able to plot the standard as well as the patient results of the APTT of the patient and the standard dilutions, and eventually take a call as to what is the result of your manual factor 8 assay. So what all I've talked till now is something which Dr. Dinesh is regularly holding workshops in our center almost every 6 months. We have a technician and a dedicated doctor who's basically involved in coagulation testing. And we do cover all these tests in our 2.5 3-day training. I'm just highlighting this to bring out the fact that even by manual testing, a lot of things can be performed, and the absence of an analyzer should not be a rate limiting step for not establishing a coagulation lab. So to summarize, in a manual setup, we have come so far. We've done PT, APTT, mixing, confirmatory, we've done inhibitor screening, we've done factor assay. What more? So we still can do some things more, like we can do a clot solubility test, like ma'am just pointed out, when we are suspecting a factor 13 deficiency, a patient with a deep bleed but normal APTT and PT results, platelet count is normal, a clot solubility test can be done manually, and though the sensitivity is low, but it is still you can still go ahead and do it, and if it is positive, it will help you to establish a diagnosis, though a factor 13 antigen assay is definitely the test of choice, which would diagnose or rule out factor 13 deficiency. And if you have a ICU setup in your hospital, and they are suspecting you have a case of a suspected DIC where both PT, APTT, thrombin time are prolonged, the platelet count is low. This is a card test again, which will help you to screen for the presence of D-dimers, and all you need to do is ascertain the clumping by putting up a negative control and ensure whether there is D-dimer or not. So I personally feel if there is somebody who's doing it till this level, they can pat their backs. You are doing a really good job, and supposedly now you get funds, you can go ahead for automation. So here we have Dr. Dinesh, and we have 2 observers currently posted in our institute, and we can see that Dr. Dinesh is helping them out to help set up the manual lab at their when they go back. So if you have a long list of investigations, if you are in a tertiary care center and you really need to maintain your turnaround time and handle a number of tests, you are running against time, moving on to automation would be a good idea. The needless to say, if I ask you what is the advantages of automation, it has a high throughput, it is rapid, more precise, facilitates data storage, you can perform different time of tests, it reduces your turnaround time, you can improve the quality of the test and reduce the need for repeating the test. But again, when you move to automation, you really need to have a good funds. You need to have a good knowledge of what your equipment is capable of handling. The cost per test increases, the dependence on the equipment increases, and you really need to ensure that a regular technical maintenance of the equipment is being performed. So like जंग पे जाने से पहले आपको अपना सारा एम्यूनेशन पता होना चाहिए. So before you actually plan to buy an analyzer or you get it on a reagent rental basis, it would be a good idea to know what is available in the market. So in terms of availability, if you see majority of the automated analyzers, they work on two methods of endpoint clot detection. That is, it can either be a mechanical method or it can be an optical method. So, and further in optical, it is photo-optical, chromogenic, immunological, nephelometric, and maybe a few more. But briefly, if you see a clot, this is a photo depicting the mechanical method of clot-based detection. There is usually a magnetic bead there in your cuvette, and as the sample clots, the movement of the bead stops, and that is how the endpoint detection occurs. So using this electromechanical detection technique, you can perform all your routine tests, PT, APTT, thrombin time, factor assays, LA, etc. And the advantage of this is that it has less interference with hemolysis, lipemic samples, because it is actually eventually measuring the endpoint, that is the how much time it is taking for the sample to clot. But it has its own limitation. If the fibrinogen levels are very low, then it might not really give you very accurate results. Secondarily, we have these photo optical detection methods. Many analyzers are available which have this photo optical method. Again, by this photo optical detection method, if you are planning to buy an analyzer with this principle, it has a lot of number of tests which it can do, ranging from PT to highly specialized tests. But you should remember that when you are going for a photo optical method, the factors like lipemia, hemolysis may interfere with your test results. But there are now analyzers which have different wavelengths to detect these interfering factors like sysmics, and then they use that to kind of जो interfering factor है उसको उस wavelength पे read करके you can subtract, and they have automation to address these pre-analytical variables as well. So that is it. So then we have chromogenic methods. When we talk about chromogenic method, one of the common tests where chromogenic method is employed is when we talk about a factor assay. So suppose this is how it will work. Suppose you have your factor 8 in the test sample. You incubate it with factor 9, 10 so that this factor 8 is activated in the presence of calcium and phospholipid. And this is actually an example of an indirect chromogenic method where first, you are activating your factor 8 in the presence of these cofactors and other factors to ensure that factor 10A is produced. Once the amount of 10A which is produced is proportional to the amount of factor 8 which was present in the plasma sample. So this factor 10A will then act on my chromogen which is tagged to a chromophore, and this factor 10A will cleave this chromophore, and because of which this colorless substrate now gives a yellow color which is then detected by your analyzer, and that helps you to ascertain what is the initial factor 8. So more the factor 8, more will be the factor 10A, less factor 8 will give you less factor 10A and less change in the OD. So this is a more sensitive test. It is set for factor assays as well, and this is a principle which is also used for many factors assessing in the assessment of thrombophilia workup like protein C and antithrombin 3. Then there are some tests which are done on the basis of immunoturbidity method, like the free protein S estimation, factor antigen levels, D-dimer, even von Willebrand antigen levels are based on these principles. So now you know what is available in the market, and now you have to, and you also know what is your daily workload. what are the tests which you are expecting at your center, how much staff is available, how much space is available, how much workload are you expecting to expand or increase in the next 1 or 2 years, and is there sufficient storage facility for the samples which will be pouring in. This is what you need to ascertain from your end. And when you look at the analyzer, you need to know on what principle the analyzer works, what is the throughput, what is its test menu have to offer, what is the acceptable minimum sample volume which the analyzer can take, what is the dead volume, how good is the technical support. Those people who are actually into running a lab will know that, जब breakdown होता है तो दिल भी बैठ जाता है. You really, have to have a good technical support to ensure that your downtime is minimum. And when you talk about the accuracy of your results, there is a long list of parameters which have to be taken care of. What is the precision? What is the accuracy? What are the interfering substances? What is the onboard stability of your reagents? What is the rate of carryover? And so on. So let us see a few points about how one is supposed to go ahead and validate the equipment which you plan to buy for your lab. So this is just a diagram, photographic depiction of what all is available. You have semi-automated analyzers. So these are usually, they have a work on one principle. Like this is an example of a Stago analyzer, which is basically working on a mechanical. So you cannot really do assays which are chromogenic or photo-optical based on this analyzer. Then there are many more analyzers which are now available in the market, which are either based on mechanical or photo-optical, and they are also simultaneously able to take care of your chromogenic assays and turbidimetric tests, which are assessed by the turbidimetric method. If you actually look up the literature, there are guidelines which are available, which tell you that how you should go ahead for the evaluation of your hemostasis analyzer reagent test system. What can be the instrument specific issues, and what can be the what you need to take care of, how to plan the evaluation of this test which you are going to introduce in your lab, how to plan the overall functioning of a system, and then assess the reference interval, the precision, accuracy, and the comparability of your equipment with is your equipment giving the same result as it would give in any other lab which is also running the test in a similar standardized manner. So the planning and evaluation will involve multiple steps. Naturally, you will have to talk to your the team which will be involved, the analyzer which is there. It'll give you some prerequisites. It'll give you training basics. It'll tell you about the basic troubleshooting, what reagents you have to select, the calibration, linearity, precision, running controls, setting reference intervals, again, comparability of your results with any other lab. What is your reportable range on that system? What is the limit of detection, and what is the limit of quantification? And finally, quality control. So I'll just briefly go ahead, and those who are actually willing to, or who are actually going on to, are in a stage where they are going to procure analyzer, I would say it would be wise to go through these articles and, increase your knowledge so that you know exactly how to ensure that you set up your equipment or validate the results of your equipment properly. So these are some general things which one has to remember when they are doing a reagent selection. Like for example, for a PT reagent, any ISI which is close to 1 which is basically recommended, because that the closer the ISI is to 1, it indicates the sensitivity of that PT reagent to factor deficiency. So ideally it is written that between 1.3 to 1.7, but as close to 1 is, I would say, the best that you can use. Your APTT reagents should be sufficiently sensitive enough so that any factor level which drops below 30% should result in a prolongation of your APTT assay. The degree of prolongation for lupus anticoagulant varies widely, and so when you are testing for LA, the reagents you have to use a LA sensitive APTT reagent, and these are not what you usually use for a routine APTT test. Then you need to ensure what is the stability of the reagent on the instrument, how to cut down the cost, how to ellicott, how to ensure that you can use the reagent to the maximum. And this is one of the areas where most of the newer analyzers are working on, so that Once the reagent has been reconstituted, the stability of the reagent on the instrument is increased. That will actually help you to cut down the cost of the test. Other things which you need to keep in mind while you are thinking of validating the equipment is that you need to ideally do one assay each for different methodologies. Suppose it can do optical testing routine where PT, APDT it is doing, then it is also doing chromogenic assay, then it is also doing some immunoturbidimetric assay. So all these different principles should ideally be tested, and the results should be verified by running your controls to see that the machine is performing optimally. You need to run normal as well as abnormal samples, which are close to the extremes. That is, there must be some range for which your equipment has a linearity. So what is ideally recommended is that for PT and INR testing, at least 40 samples from patients receiving oral vitamin K antagonist should be run so that you can detect the upper limit of abnormality which your equipment can report accurately. For APTT, you need to run a number of normal samples of patients receiving unfractionated heparin, patients with LA, and patients with different levels of factor deficiency. So this is, I'm not stressing on the number over here, but yes, you need to run different types of samples to ensure that your analyzer is giving accurate results in all these different settings. So how do you ensure that? For that, suppose for an assay, this is a calibration curve for factor 8 assay, it is doing 6-point calibration. A minimum of 3 different calibrations is recommended when you are doing PT or APDT based testing. And for example, this is another graph where this is where von Willebrand antigen testing is being done. So we have this calibration curve, and then controls are being run. Usually one normal and one abnormal control has to be run. So a standard is something which has a fixed value, and that is being run in dilutions to ensure that there is a linear result by the analyzer. Subsequently, we run the controls. A control is something which has a range within which your analyzer should give a result. So this R value, it is said that it as close as 1, it is good. So this is 0.99. So indicating that your calibration curve is very good, and the machine has correctly made the serial dilutions and read the result properly. So I'm not very good at statistics, so I'll just leave at that. This is my level of understanding, and there is much more to it what you actually otherwise see. So there are these parameters which you need to know, that is accuracy, precision, specificity, analyte range, that is what is the lowest and the highest value, what is the limit of detection and limit of quantification, and then there it is written what are the acceptable values. For example, to ensure the accuracy, meaning that you get the correct result. So you need to know 10 you need to run samples or 10 runs of a sample with a known value to ensure that you are getting the same correct result. Precision means that you are getting one result consistently. It may not be accurate, but ideally, so that is why precision and accuracy both are equally important. For precision, it is said that there should be intra-assay and inter-assay replicates, at least 10 to 20 replicates of sample on the same run, and 10 replicates in different runs. And what is the acceptable variation which is there to ensure that your analyzer is actually precise. So then coming on to the next very important thing is establishing reference range or the reference interval for your different tests. Usually what we tend to do is we kind of tend to adopt what the range is being mentioned with the kit. But for PT, APDT, I would say, and you really need to go ahead and standardize your own reference interval with the reagent which you are using. You need to prepare that pooled normal plasma, collect samples from, as per the recommendations, it is at least from 120 normal healthy individuals. And this is also mentioned for setting range for lupus anticoagulant. And so I know this is what is an ideal recommendation, but it may not be possible to follow it and when you are actually doing it routinely. And then what is more important is that the subjects or the so-called controls which we are taking are actually proper and adequate. There's a proportionate mixing of the healthy males and females. We should avoid any kind of pre-analytical sources of error, because that will result in an abnormal setting of a reference interval. And again, what they say that in the absence of appropriate donors, like for a pediatric population, you might use, because it might not be possible to collect samples for such huge numbers. So an appropriate literature, validated literature for that population can be taken up. So इतना कर लिया, automate भी कर लिया, सब कर लिया, machine भी sanitize कर ली, but still you have another long list of investigations which are not being handled by these analyzers, and you have, बहुत पैसा है. So the list can go on. You can go ahead and buy light transmission aggregometry, multiplate electrode aggregometry. These are basically equipments which will actually help to assess platelet function and then verify now, which is used for monitoring the drug, if antiplatelet drugs. Then you, as ma'am had said, highlighted in the previous talk of when she presented some good cases of bleeding diathesis. So the global test of hemostasis actually give you much more information of a clot kinetics. Like PT, APDT, what you are seeing is actually the end, that is the clot is being formed. But what was the kinetics by which the clot is being formed and what happens after the clot has been formed is something is covered, that is being covered by the global tests of hemostasis. And as the name indicates, it is actually telling you more in depth about the kinetics of the whole process of coagulation and not just the endpoint, that is the clotting. So these tests are also coming up in good use for patient care. Like we hear a lot about the clot wave analysis now. And then we have a lot of point of care testing. I really don't know anything about the last 4 tests which I have written, but since they were there on the internet, so I wanted to add on key. If you are a research lab and you have funds, then there are many new things in terms of point of care testing which are coming in, which can add on in evaluating a patient of a bleeding disorder. थ्रोम्बिन जनरेशन ऐसे वाले तक मुझे थोड़ी बहुत जानकारी है, उसके बाद I have no knowledge. So with great power comes great responsibility. So when you talk about automation and coagulation, it demands a considerable wisdom and often intuition to interpret output. ये नहीं कि machine को जो दिया और जो output आया वो आपने वैसे ही interpret कर लिया. So you have to ensure that the quality of the results, this is a huge responsibility to ensure that what your analyzer is now reporting is accurate. So you need to take care of quality control in your lab, and this can be done by using internal quality controls, which ensure that there is a consistency in the day-to-day method and minimum day variation when you are running the same sample again and again, or you are running your control samples. And then you can participate in external quality assurance programs to ensure that are the results which are produced from your lab comparable with that which are produced from other labs. And when you run these QCs, it actually takes care of all these phases of testing, that is pre-analytical, post-analytical, as well as analytical. So IQC way, mostly this comes with the analyzer. They'll give you some control materials which are like lyophilized or freeze-dried. There are recommendations as to how frequently you should run your QC, but at least I would say once per day is definitely in. And if your sample load is high, you might have to do it at least twice. Minimum of 2 level controls should be run, at least 1 normal, 1 abnormal. Then there are QC rules, which we all hear of, the Westgrad rules, which are there. We should follow that. And if your results are not following within the recommended set of these rules, then patient testing should be stopped and you should look into what is the ongoing error. So this is, for example, example of the EQA, which are our lab participates, where we get samples from CMC Vellore. And I've just depicted how so this is for the test prothrombin time. It will tell us what is the sample, what was our result, what was the peer group assigned result, what is the limit of acceptance in the performance, how many number of participants were there, and our performance is within consensus. And this is how they depict that this is the range within which the test result should have come, that is less than 12.92 and more than 17.48, and so on. So if you actually participate in an external quality control program, it adds to your confidence that your lab is actually doing good. And if you're not doing good, it will help you to identify that which test parameter needs your attention, and where is there a false trend or something where your Levy-Jennings charts will point out that is there some trend in which there is a bias where you are consistently, your controls are not in the expected range, so you can address your issues. Lastly, when you are doing so much, you need to have a good documentation. You cannot just bury yourself in this pile of records. This has to be arranged properly. You should have stock registers. When was the stock received? Uska expiry kab hai? Sample records, QC records, breakdown records, and all these will eventually help you in a lab accreditation. So to conclude, there are multiple options available when you are आपने अगर ठान ही लिया है कि आपको coagulation lab बनाना है और काम करना है, then you are having multiple options. You need to inspect the lab needs, what is the available infrastructure. You need to identify a dedicated manpower who will, be responsible for all this testing. You need to have good funds to see what all you can go ahead and buy. Again, there are options in semi-automation and fully automation depending upon your center needs. Most important is to set up your own lab reference intervals and ensure QC. So this is our team in the department who keep pushing us for doing more and more tests by bringing forward more challenging cases that keeps us on our toes कि यार अभी भी नहीं बता पा रहे कि इसको bleeding क्यों हो रही है. So then that pushes us to introduce new techniques and ways by which we can help to establish a diagnosis. And this is our coagulation team, Dr. Dinesh, and I'm sure many of you are familiar. Then we have Biswas and Meena, who are the pillars of the lab for the past, I would say, 15 years now. Thank you.
Thank you, Dr. Ruchi. It was such a wonderful presentation from such an experienced person who's doing these things day in and day out. And I mean, seriously, lots of practical aspects covered. Somebody who doesn't know much can really start up with a few things now. And yeah,
Thank
so it
you.
was really nice. I think if you're doing properly PT and APTT also, then if you're giving an accurate value precision, then that also requires a lot of effort, you know.
Yeah.
बाकी की बात तो बाद में आती है.
Right. So, मतलब I'd just like to highlight to the public की presentation में डालना एक बात होती है, and I have been in centers where there has always been automated analyzers. So we at my student level at least, and subsequently also manual testing पे हमने बहुत नहीं किया. But in the past 3-4 years now that Dr. Dinesh is regularly conducting these workshops, even it has been an eye opener for me also, that even though there are actually many hospitals in India also or labs जहाँ पर semi automated तक ही analyzers available हैं. So मुझे ऐसा लगता है कि जो हमारे यहाँ से ट्रेनिंग लेकर के जाते हैं, एटलीस्ट हम उनको ये बता पाते कि आप फैक्टर डेफिशिएंसी तक तो बता ही दे रहे हो, मिक्सिंग करके इनहिबिटर भी है कि नहीं वो भी बता दे रहे हो. So I think
Correct,
if they are
correct.
really dedicated, they can pull up their lab to a very good extent. And when they'll show good results, I'm sure they'll get funds to, move on and procure newer things also then.
Yeah, actually automation requires a lot of funds, and especially those investigations जो आपके पास कम आते हैं, they are not coming up routinely every day.
Yes.
उनके ऊपर funds लगाना थोड़ा सा मुश्किल हो जाता है, some rare factor deficiencies and all. That becomes a challenge.
So these labs जो periphery में है, what they can do is at least they can siphon out उतना screening करके they can then guide the patient कि it is suspected this defect, and then they can refer him to a higher center. So even
Right.
that would be of great help then.
Yeah. Thank you.
I don't think there are any questions in the chat box क्योंकि ये बहुत ही जनरल टॉक था, इसमें मुझसे कोई क्या ही पूछ लेगा. So I think that is it.
I think Dinesh Chandra want to ask a question to you now.
Yeah. Good morning, everyone. So wonderful talk, ma'am. Actually, what I just want to add, there is a little bit thing whether we have to set up in a government setup of corporate sector or private sector standalone one lab. So that should be little bit things are different. So one thing we have to look for the fund. Initially, fund management is very important, especially when it is comes to the private lab, standalone lab, or in the corporate sector. So that should be looked where my first year budget is maximum going to be spent. So like for rental or purchase the things, instrument and all those things. So that should also be keep in mind. Um, that thing is very important when actually you go to establish the lab. So that is one thing that I think should also keep in mind.
I think that is one very important thing that should be kept in mind. पैसा नहीं होगा तो आप करोगे क्या?
No,
स्टाफ
no,
नहीं होगा तो आप करोगे क्या? And then I would also say that अगर clinician आपसे जो चीजें मांग रहा है, that is a priority which you need to set up in your lab then.
yes.
So that will be the driving force for funds also. That will be the driving force for anything actually.
Yes. So that is thing. So पैसा है, लेकिन पैसे को कैसे खर्च करना है और कहाँ खर्च करना है, और पहली साल मुझे किस जगह पे ज्यादा खर्च करना है और सेकंड ईयर मुझे किस जगह ज्यादा खर्च करना है. So that should be one thing. And other things, when in government hospital, obviously we don't need any permissions. But if you're going to start the private labs, then from municipal corporation, from fire, from safety, from there is a lot of accreditation, laboratory. So good practice in medicine, that there is a lot of certification you need to start your lab also. So that is also have to keep in mind. Okay. All these permission you needed before you going to plan that start your lab. That's all from my side. And very nice talk, man.
Thank you, Dinesh. I think we can move on to the next session then.
Thank you, Dr. Lucy.
Thank you.
I think we have a break now. Can the organizers just tell that when do we have to come back for the next session?
Half an hour.
Half an hour. So that will be 11:45, right?
Yes.
Okay. Thank you.
Today. It's mainly the prothrombin time, the activated partial thromboplastin time, and the thrombin time. They are they do give us there's a starting point and the end point is the formation of fibrin, but they do not tell us anything about the process of clot formation, the clot stability, clot lysis. We have no idea whether the coagulation factors are contributing where there's a problem there, or the platelets contribution that is not sufficient, which level the problem is arising. And the most important problem which any is that um, even the fastest and the most efficient laboratory will give a result after about minimum of 30 minutes, average at least an hour, because it takes time for the sample to travel to the laboratory and the laboratory to process it. So it is the present coagulation management profile not uh, is not sufficient to is not adequate for the initial acute management of the patient, and it is not good for monitoring. Wherever there is a repetitive analysis is required, it is not adequate for that. So these are two challenges which can be met by point of care assays only. So next slide, please. Next slide, please. So what are the advantages? Basically, as I said, they're extremely rapid. That is the reason for the whole point of care testing protocol, is that the turnaround time is very low, in minutes, in 5 to 10 minutes. And the good thing about the tests that have been developed for coagulation and bleeding disorders is that largely they use whole blood. So we see a situation in the tests also where the clotting factors, the platelets, and the RBCs are interacting, and that simulates the in vivo situation. And as I said, they give additional information about instead of just a starting point and an end point with the fibrin clot, they allow assessment of the process of clot formation, the strength of the clot, the lysis. All this is given in real time. And so another additional advantage is that we can, with the help, I'll elaborate on it further, that it is possible to evaluate the effect of the various oral anticoagulants and the platelet inhibitors available to us. That helps guide therapy. And these assays, the graphs obtained therein, they also lead to a reduction in the non-evidence based transfusion. What I mean by that also, I'll elaborate a little later. But what happens is, like, I'll give you a very common example. A patient comes with, in a case of trauma, with hypovolemic shock. We infuse a lot of FFPs, and then we realize that leads to further dilution of the coagulation factors, and the patient then bleeds further. So if we know exactly where the problem is it because of coagulation factors? Is it because of platelets? Is it an excess fibrinolysis? Then we can treat accordingly, and we can give the correct transfusion. Do we need to give a fresh frozen plasma? Do we need to give a cryoprecipitate? We need to give platelets? What is it that we need to substitute if the patient is in a hypercoagulable? Of course, I'm talking mainly about hypercoagulable states, but this also applies to hypocoagulable states. Next slide, please. So then, obviously, if something is so great, why have we not adopted it? Why has it not been adopted so far everywhere? It has certain limitations. First of all, in a country like India, these tests are very expensive, and that is the biggest, I think, the hurdle here. And the another hurdle is that I wouldn't say hurdle exactly, that despite the best of conditions, the sometimes the in vitro tests may not mirror the in vivo condition. So they are not absolute. And another problem that any and every point of care test faces is that it is being performed by staff that is not trained in laboratory protocol, in laboratory procedures. So non-hematological staff, we need to train them to ensure their competency and their efficiency. And anywhere outside the laboratory, it is not possible practically to hold on to the quality assurance standards that we can hold on to, that we can adhere to within the laboratory. Another, I would not say the limitation of the test, but a problem in present times is the studies that have been conducted so far are very few. And the studies have been conducted on a limited number of patients, and quite maybe unfortunately, I would say, they are largely studies conducted by the very companies that have developed it or sponsored it. So it is what we need to help in adaptation of these, in really adoption of these wonderful machines that have been developed, is that we need multi-centric trials on a large number of patients. And that is when we will develop faith in these. But before that, we need to know about them. What are the machines available? What are the various investigative modalities available? Next slide, please. So before going on to this, I think I'd like to pause for a minute and give a quick recap of the coagulation process. The commonest way is that the vessel is injured, and the vessel immediately undergoes a vasoconstriction in response to that. But the coagulation process, that's called it's transient. The coagulation process is set into motion by the formation of the platelet plug. The platelets, they have a receptor called glycoprotein 1b9, and that adheres to the von Willebrand factor, and which, via the von Willebrand factor, it adheres to the, with the help of von Willebrand factor, it adheres to the collagen, which is exposed in the subendothelium. So that contact is very important, and that is often replicated in the tests, that contact factor, and this is the intrinsic pathway, and which is activated because of vascular injury typically. And then there's a cascade of the one factor activating the next. So first factor 12, then 11 is activated, then 9 is activated, then 8 is activated, and together activated 8 and 9, they activate factor 10. And this is called the intrinsic pathway. I'll just pause here. There is coagulation can also be activated by passive tissue injury by external sources, in which case the tissue factor or tissue thromboplastin is released, which activates factor 7. and this further activates the factor 10 and converts it to factor 10A or activated factor 10. So in all these processes, the ionized calcium and often phospholipids, they also play a role. They are often essential components of many of these activation reactions. So the intrinsic pathway, as we know, is measured by the APTT, and the extrinsic pathway is measured by PT. And then there's a common pathway, both these, whatever the source, then after factor 10 is activated, it activates the prothrombin or the factor 2 and converts it to thrombin. And then thrombin converts fibrinogen or factor 1 to fibrin. And then the fibrin is stabilized, is activates factor 13 or fibrin stabilizing factor. And then there is cross linkage of fibrin occurs, and in this fibrin meshwork, the platelets, the RBCs, all they get trapped, and then secondary plug is formed. And then there's a clot retraction, and later on vessel gets clogged because the gap is clogged because of this formation of this clot. But then later on fibrinolysis occurs, which enables the further movement of blood. So there is a clot retraction and fibrinolysis process which can occur after this. So the key players are the coagulation system and the platelets. And we have to remember that the starting point is generally either a contact or the tissue destruction and the release of tissue factor. Keeping this in mind, let us just move on to the what are the tests available. Next slide, please. Next slide, please. So we have three categories of tests: the viscoelastic test, the platelet function test, and the point of care coagulometers. So viscoelastic test, nahi, piche please. Piche chale jaiye. So this is the basic principle that you take a cup. It was the first viscoelastic apparatus was like that. It had a cup with a blood in it, and there was a pin which was suspended through a wire, which was connected to an electromechanical transducer. And this cup, anticoagulated blood was put into this cup. The cup was rotated, and because of the coagulation, the movement of the pin, what the pin was sensing, the mechanical impulses would vary because of the formation of clot, and this was then transmitted via the electromechanical transducer and computed in the form of a graph. That is the basic principle. Now that there is because of clot, there is the viscosity of the clot, there is a certain change in the impulse and in the impedance, and that is transmitted in the and depicted in the form of a graph. So what are the machines that are available? Next slide, please. So one is that, as I said, because it is a real time of process, it is every minute the recording is going on and the graph is forming. So it displays all these stages: clot formation, clot stability, clot lysis, all of it. So if we obviously get an idea of the clot formation, which is mainly reflects the coagulation disorders, we get an idea of that in 5 to 10 minutes. Then clot stability, for that we need about 10-15 minutes, where the role of the platelets also becomes very pronounced. And if we want to assess the clot lysis, we will need about at least a 30-minute time span for that. But it is all happening real time. So we can gauge. So as along with the patient, while we are managing other things, we can gauge the picture as to what the problem is and at which level the problem is arising. Where is it that the graph is not matching with what should be, what is normal for a patient? So, and it is, we use citrated whole blood at 37 degrees centigrade, just like we use for PT and APTT. And then another thing that we can do is we can add different reagents to classify the hemostasis effect. Of course, from the stage of the graph, we have an idea. In the beginning, if it's problematic, then it's probably coagulation, and the latter part, coagulation and platelet have a role when the stable clot is formed. And then the latter part, after the fibrinolysis, obviously then it's a problem in the fibrinolytic system. But by adding different agonists and antagonists, we can make out exactly where the problem lies and what drugs can be used. So this is all. So it allows detection of many things: the coagulation initiation, the fibrinogen level, fibrinolytic activity, platelets contribution, and as I said, the role of therapy, various therapeutic agents available. Next slide, please. So we have three so three basic assays are available. The rotational thromboelastometry, which is more common in both are developed in the US, but ROTEM is more common in Europe. Then thromboelastography, which is more common in the US, and much later, the sonoclot technology was also developed. So this is all. The basic principle is that there's a cuvette containing citrated blood, which is kept at 30 degrees centigrade, and there's a pin. The difference is that in ROTEM, we have the pin rotating, and there is the electromechanical transducer is connected to that. In thromboelastography, we have the cuvette rotating, but the effect is the same. It is just basically the measuring the viscosity and the viscoelastic characters of the clot. In sonoclot, we have a plastic probe that is disposable, that is oscillating, not rotating, right? So next slide, please. So this is what the machines look like. You see that in all cases there is a graph. And do you see that in the second one, where there's a ROTEM, there is a graph. There are 4 channels that are being formed. The graph is slightly, I'll show you, it's become a slightly wine glass shaped graph. And this is probably at the stage where a mature clot is just being formed. So it depicts that. Here also this is a thromboelastograph where we feed the blood sample here. Here the blood samples are here, and here this is the sonoclot, which is developed by Cienco, all developed in USA, and we put in the sample here. Next slide. So what is the principle? As I said, both of them have a cuvette or a rotating. All of them have a cuvette or rotating cup, which has a blood sample, citrated blood maintained at 30 degrees centigrade. And then we add various activators. So they're often parallel channels depicting different activators. And that's a simultaneous assessment is made by acting different activators and also sometimes adding antagonists. And then in the first one, the TEG, the pin, and it's a torsion wire. So it's a completely connected to an electromechanical transducer, which is labeled as 4. In ROTEM, you have an the pin is rotating, and the difference is noted in the motion is noted by not by mechanical but by optical signals. We have a mirror here, and this is an optical detector. So this is the detection system is optical here. And then again, there's a data processor which is presenting it in the form of a graph. In sonoclot, we have a disposable probe, which is attached to the electromechanical transducer head, and there is again the sample in a cuvette and which contains activator. So there are parallel channels. I'll talk a little about it, not in great detail. Please, next slide. So I was talking about the various assays that are available. I'll talk about the thromboelastograph and the rotational thromboelastometry because they run quite parallel to each other. So what are the assays available? And mind you, this is simultaneous testing going on. So this is the native TEG, which is there's recalcification is done. So the reaction time, the time to formation of clot is very long. That is the baseline, you can say. Then the one that is taken as a standard at the other end is the RTEG or the rapid TEG. In this, what we do, we add kaolin to simulate contact. We add tissue factor to simulate, of course, the tissue factor, the extrinsic pathway. And so in this is the quickest of them all. And in this, the role is played by the intrinsic pathway, the extrinsic pathway, as well as the platelets in the blood. So anything else beyond that, we compare with this. Then we can do a KTEG where we add just kaolin. So kaolin is replacing surface contact. So which pathway are we talking about in this? We are talking about the intrinsic pathway. Of course, in the formation of a clot, the platelets will play a role here. Now, suppose we want to find out just about things like the latter heart, the common pathway, or even the extrinsic pathway. Extrinsic pathway, apart from the common pathway, just has factors 7 and tissue factor. So tissue factor we are substituting from outside. And what we are doing is there is also the role of platelets. We want to negate that role. We mainly want to find out about the fibrinogen levels and whether the fibrin polymerization process is right or not. So that if we want to do, we have to eliminate the role of platelets. So here we put in the tissue factor. which does not have so many coagulation factors. It is just factor 7, with the deficiency of which is quite rare. We are mainly focusing on the fibrinogen here. And we inhibit the action of platelets by putting in a platelet inhibitor, which is like here we put in abciximab. The same pattern you can put in some other platelet inhibitor also, which we do in ROTM. But we want here to check for the fibrinogen concentration, whether functionality of fibrinogen, the fibrin polymerization process, whether that is okay. We want to check for this. So it's called TEG-FF or functional fibrinogen. And sometimes the patient may already be maintained on heparin. So we want to see what the baseline, I mean, other than heparin, if we remove the effect of heparin, what is the coagulation profile like? So we have, it's like rapid TEG only. We put in kaolin and tissue factor, but along with it, there is heparinase in it. So that nullifies the effect of heparin if it's present, and it helps assess the heparin effect. The difference between the two will show the effect of heparin, whether the heparin is beneficial to the platelet and to what extent. Next slide, please. We have a parallel set of assays. Next slide, please. In ROTM also. The only thing is, like in rapid there, we were simultaneously activating the extrinsic and intrinsic pathway. Here we have two channels, extem or intem. In extem, we put just tissue factor. So we activate the extrinsic pathway and there's a role of platelets is gauged. In intem, we just simulate contact by you putting in ellagic acid. And also we put in phospholipids. And so we get the role of intrinsic pathway and platelets is obtained through this. Now, similar to TEG-FF, we put in a platelet inhibitor here. We make an extem kind of a pattern with putting in tissue factor, and we add a platelet inhibitor. Here we add the cytochalasin D. And as a result, there is a reflection. Fibtem is a reflection of the fibrinogen concentration and the fibrin polymerization. And it is independent of platelets because we have nullified the effect of platelets by adding a platelet inhibitor. Then we want to find out whether the antifibrinolytic therapy, whether maybe there's a problem in fibrinolysis. And we don't want to wait till so long, and we want to check out whether antifibrinolytic activity will help in any way. So we add an antifibrinolytic inhibitor. It was called Aptem because initially aprotinin was used. Now we add tranexamic acid because that is the mainstay of treatment, antifibrinolytic treatment nowadays. Otherwise, it's extem based. We add tissue factor. And so that helps us understand whether adding an antifibrinolytic, if we compare it to the extem, we will get to know whether adding an antifibrinolytic has helped the patient, whether the graph has normalized. And then we can then decide whether to add that as a therapy protocol. Then like we have had HTEC there, similarly, we have another thing where we have an intrinsic coagulation pathway. That means we will add the tissue factor and we will simultaneously add heparinase to nullify the effect of heparin and to assess the heparin effect. This is especially useful where there is a patient is often on heparin. So next slide, please. Now, next. Then this is what the graphs that we get. So as you can see that in the beginning, the first part is where so it is showing the real-time formation of clot. The first part, is my cursor visible? The upper part, the graph is exactly similar in TEG and ROTM. The terms that we use are different. The first part, is my cursor visible? The first part represents the formation of clot. So the different terms are used. We call it clotting time in ROTM. We use the word reaction time in TEG. And the clot strength or the clot firmness is measured on the y-axis. Its time is plotted on the x-axis, and that is a continuous graph. It is being displayed on the monitor. So the clot strength or firmness is depicted as amplitude, which is on the y-axis. You can make out here. So the time from the beginning of the test to the formation of a clot, which is 2 mm amplitude, that is defined by different names. It's called reaction time or clotting time. Then the time taken to formation of a clot from 2 mm to 20 mm amplitude, that is typically when the clot is forming, the thrombing, the first. So that is called clot formation time in ROTM and kinetics time because it's reflecting the clot kinetics, the thrombosis kinetics. So, and the angle, the angle between this starting point and the point where it reaches 20 mm, the tangential angle is called alpha in both. And basically these two, K and alpha, they represent the kinetics and the velocity of thrombin generation. The first part typically has a role of just the formation of thrombin, the initiation phase. Then gradually the clot gains more and more strength. So here on the platelets also start playing a role. And here the maximum amplitude, I think the diagram is not so right, maybe it should be here. The maximum amplitude is called MA in TG. It's called maximum clot firmness in Rotem. And then thereafter, the clot starts lysing. When you see there's a tapering end, it starts looking somewhat like a wine glass. And because it tapers off to a very thin kind of a stalk-like thing at the right, further right. I have taken this picture because it gives a good analysis and compares the two terms. But later on, it will taper off. The clot will not completely dissolve, but it will become a very thin kind of a tapering off line. So it starts looking like a wine glass somehow. And so that is if we want to what we do is we take the amplitude at 30, the percentage, we compare it with the maximum amplitude, and we take the percentage of after 30 minutes, we call it clot lysis, and that gives a good idea of the fibrinolysis. Next slide please. So these are the various terms, they are comparative. So as I said, the R value or the CT that reflects the velocity of thrombin generation. So if this part is getting abnormal, what we do is we assume that the patient needs FFPs, he needs coagulation factors. Then beyond that, if the clot formation velocity is not sufficient, alpha or K is slightly abnormal, then we also think of giving cryoprecipitate. But if it goes, the strength of the clot is, the firmness of the clot is not sufficient, the MA or MCF is not sufficient, then we think of giving platelet transfusions. And if there is a problem in lysis, we will know that the lysis index is or the clot lysis CL or LI, we typically take at 30 minutes. We do not wait sometimes for maximal lysis. We need not wait also. We get a good idea by 30 minutes. So because it's a percentage of the maximum amplitude, the maximum strength, how much. So then there's a problem with the fibrinolytic system. And then maybe we need to administer tranexamic acid or antifibrinolytic drugs. So that gives us a very good idea as to what therapy and what transfusions also to give. And unnecessary transfusions, which may even harm, as I gave the example of giving excess FFPs and thereby, or excess just volemic, you are just substituted volume and thereby diluting the coagulation factors, that is we can prevent that. So and of course the therapy is further guided by the various channels, as I mentioned, by checking out which of the mechanisms is defective. And can I move on now? So in sonoclot also there is a different kind of graph that is obtained. Next slide please. There's a different type of slide. So in the beginning, when the clot formation starts, that's called activated clotting time. Then the fibrin gets converted to a gel, and that is called fibrin formation. So there's a peak at that. The first peak is here. That is because of fibric formation. Then the clot retracts, and it becomes stronger. So there is a second peak again in the viscosity. Basically, it detects the change in viscosity. So that typically is depicted highly by the clot retraction. And the parameters that we use, next slide please, is that there are many parameters in this also, but largely just to start of clot formation, we use the activated clotting time, which is in seconds. Then the velocity, just like we were using for the alpha angle or the K time, we use what we call the clot rate. This is the we measure it in the we measure the clot units, we call it. It is typically that angle that we hear. The steeper it is, that means the higher the velocity. And the amplitude or the strength of the clot, we use peak amplitude, and the time for that is the time to peak. So there are many other parameters, but these are the 4 common parameters. But the signal, the graph here is slightly different, and it needs a different kind of interpretation. I'm not going into detail. The principle is the same basically. That and Rotem and TEG in any case are used much more as compared to sonoclot. So now we move on to the second set of tests. Please, next slide, please. the platelet function test. So what we do is here the platelet number we can detect using platelet count. But what about the platelet function? So these give a quantitative assessment of the platelet function. And there are three methods that we use. One is we call the whole blood aggregometry, where the platelets aggregate, and based on that we have which is a change in the properties. I'll talk about it later. Then the platelet adhesion, we kind of simulate the condition in a vessel using shear stress. And then of course there is the aggregation, the level of aggregation we detect it using optical methods. So there are three methods. In platelet function, often there is a discrepancy has been found in the in vivo and in vitro, but so definitely it provides supplementary information. It is information. It is not as reliable as viscoelastic tests. So they have to be taken in with, I mean, along with the other parameters, they have to be considered, not by themselves, preferably. Next slide. So whole blood aggregometry, we have three systems available: multiplate, and then modifications of ROTEM and TEG only. So next slide, please. So what we're doing in viscoelastic methods is basically we have two electrodes at 2 points, and we have a citrated whole blood in between. And we are and then as the platelets aggregate, the viscoelastic properties, sorry, the transmission of between the two electrodes decreases, because the electrodes are getting clotted with platelets. Sorry, not clotted. There's aggregation of platelets, and we can further check the role of various activators, because now we have platelet inhibitors. We know to decide what inhibitor to give. So we can have parallel channels and check out which of the activators is overcoming this effect, and thereby we can, or which activator is defective, and thereby we can decide, because we have different classes of platelet inhibitors. So we can decide the therapy is guided by that, by putting in different agonists which is overcoming this. So we decide the therapy based on that. So and what there are again many parameters, but the one standard parameter that we take is the curves are formed, and we take the area under the curve. I'm not sure whether you can see there are 5 channels here in multiplate, and like curves are formed. So the curve itself gives an idea as to which one, which parameter is which agonist where there's a problem, which chemical mediator is causing an issue, or which receptor is causing an issue, and thereafter we can treat it. And so, but it is a very labor intensive process. Next slide, please. So this is a diagrammatic representation that I've given. Mainly 3 set of inhibitors we have, platelet inhibitors. One is platelets get activated by ADP. And remember, it is after activation that aggregation starts. The platelet shape changes and then it aggregates. So it acts through a receptor called P2Y12 receptor, and there are P2Y12 blockers. The commonest drug being clopidogrel. Whether we should administer that, we need to know. Then there's what we call TRAP. It's thrombin receptor activator protease, and we have it acts through the PAR1 receptor. So here we give glycoprotein 2B3A antagonists can be given, which block this. A common example being abciximab. And then the most common, the arachidonic acid, by forming thromboxane A2, can activate it platelets. So we can give COX-1 inhibitors here, which is just aspirin or NSAIDs. And then their platelets are also activated by collagen, and also the von Willebrand factor activates platelets by the von Willebrand factor binds to collagen and also activates platelet by through a receptor called glycoprotein 1B9. So these are assessed under different channels called ADP test, TRAP test, ASP test, call test, and Risto test. The Risto set and what we call it. Next slide, please. Now, what has happened is in ROTEM, they have developed some parallel channels, the slightly higher version called ROTEM Delta. They have platelet channels. Next slide. So what they've done is they've put in 3 channels for the 3 main set of inhibitors that we have: arachidonic acid, and which will help detect the effects of COX inhibitors; ADP, which will help detect the effect of ADP receptor inhibitors like clopidogrel; and TRAP6, which will help detect the effects of glycoprotein 2B3A antagonists. So they've just added these 3 channels. The next one. Thromboelastography also, they've done the same thing. They've taken the kaolin activated test, basically put in a lot of reptilase and factor 12 to make the clot very stable, and then added 2 extra channels, to one having arachidonic acid, one having ADP, to check the effect of these agonists, so that the difference between the kaolin curve and this will help determine the effect of aspirin therapy or the effect of clopidogrel therapy. And to there is a separate channel, you can add the antagonist of glycoprotein 2b3a, and thereby you can decide whether which therapy to give, which platelet inhibitor therapy to give. Next slide. So we have largely, as I said, the platelet function is detected by the maximal clot firmness also, and also by the alpha angle. Alpha angle is largely the role of fibrin. Platelet, it is also has a role. The clot formation time and kinetics, that also has a role, platelet. But but mainly the clot firmness, that is affected by platelet number, platelet function, von Willebrand factor. All these are affected. So these are gradually eliminated by putting in various channels and checking out which of them is wrong. So we can compare it with the baseline thing. Like here, in case we're taking kaolin 1 as the baseline, and comparing with the graphs with that will help us determine which is what therapy to give and which is a problem area. Next slide. So there is another type is where we use shear stress. We are assuming that in a capillary we have contact because there's a rupture of a vessel. So we simulate that by putting a capillary which has a membrane having collagen as well as some kind of an agonist like ATP or epinephrine, and also it has a von Willebrand factor along with it. So that is simulating the conditions in the vessel. We just pass the blood through it, and because it's a capillary, there is a high shear stress, and then it is an automated system. It is so we use this principle to find out the platelet function, and there's a and this machine is called, next slide please, platelet function analyzer. And there's a thing, when the clot is formed, then the transmission is stops. So it's called the platelet PFA closure time. So that, as I said, it will depend on all these factors: platelets, platelet reactivity, number, inhibition, if any, platelet count, hematocrit also, and von Willebrand factor. So there are different cassettes. We load it in a cassette. We put it in the incubation well, where we load it. We keep it at 37 degrees centigrade, and then the values are read. Next slide. So next. And as I said, this is very good for differentiating between the serious diseases like the genetic problems like Glanzmann's thrombocythemia, Bernard-Solier syndrome, and between this mild inhibition that is caused by some coagulation factor deficiency or because of some antiplatelet therapy. So that differentiation is very well done on this, and it's just a disposable capillary. And now we have also an optical detection. What we do is basically there's a closed system. As you see, we can putting in the citrated whole blood, and we have fibrinogen coated bleeds, which help, and on which the platelet will collect, and we promote it using like different channels where we're using there. Here we have different agonists like using TRAP, arachidonic acid, and ADP, and thereby we can monitor the effect of the various classes of platelet inhibitors that we are giving, and the result is expressed within minutes. Now next slide please. This is prepared by Siemens actually. And last, this is a very simple thing. It is the point of care coagulometry. Next slide. We are just doing the basic tests that we are doing like PT and APTT. It's called QuaguCheck. It has we are doing this, is also being created by Roche Diagnostics. Multiplayer, I forgot to tell you, it's been created by Roche Diagnostics. So it is just a card test, very simple card test. One card in which we want to check for PT. It is coated with thromboblastin, and also there is a protease along with it. And the other one where we are checking for APTT, it is coated with Selite to simulate a contact factor, like as we were doing for coagulation for kaolin there. So it is coated. We put in just a drop of blood prick. We coat it, and and then we put in the detector, that card in the detector. What happens is once thrombin is formed, and in one, obviously the intrinsic pathway will be activated, the other one, the extrinsic pathway, will be activated. So it will there's another protease which gets cleaved, and this generates an electrochemical signal. and this is read in and displayed in the form of a digital value. So we get INR and APDT values, both of them we get. It is, next slide please, it is not very accurate. It is not very accurate. And so what we are doing is, because coagulation factors are affected by liver diseases, by vitamin K deficiency, by if there's consumption coagulopathy, like say DIC, so many factors are acting in it. And it's just detecting one whole series. It is not detecting any one pathway or any one type of activator, any one type of so what we're doing is we keep it very like it has been approved only for use of anticoagulants with vitamin K antagonists. So it has not been, it is just a very milder version of, quick point of care version of PT and APTT. That is all. So next slide. So ultimately, what is the role of point of care assays? So as we found, it is, of course, it has decreased the transfusion requirement, made transfusion much more evidence based, and improved outcomes. But which is a set of patients where it is most effective, where there is polytrauma, major trauma, in cardiac surgery where we need continuous monitoring, and in postpartum hemorrhage there also we need continuous monitoring. And there these their assays have a huge role to play. And as we discussed, they detect, they give an idea about the effect that any a given anticoagulant or a platelet inhibitor will have, and that is helps guide therapy. So it is a gold standard in hemostatic resuscitation. So just to wind up, next point, next slide. Just to wind up, what is it that the available tests are not sufficient for coagulation management, especially for initial phase, acute phase, and monitoring. So point of care assays, they allow a wide variety. They give an idea of clot formation, clot stability, and clot lysis in real time. And they also help us evaluate the effect of various therapies. So, be it whether we should give anticoagulants or platelet inhibitors, and what category of anticoagulants or platelet inhibitors should we give. And that is why there are three basic methods: the viscoelastic methods, the platelet function assays, and the point of care coagulation. And they have helped improve the outcome in many such in the acute conditions like major trauma, cardiac surgery, and postpartum hemorrhage. Thank you. I'm sorry. If anybody has any question, you can ask me. Thank you. Okay, okay, thank you. In that case, I think I tried to give a brief preview.
I must read is professor of onco anesthesia.
Pardon? Pardon? I'm sorry, I couldn't hear you. It's actually our field, but the anesthesiologists are using all this much more. So they, I think they know, they are more attuned to it, but we should know. It is ultimately our field.
And for further questions, you have to reply in chat box. Okay. Now we are moving on to the next talk.
Okay.
Hi, can you please make me a co-host so I can share my screen?
Wait a minute. Sir. Can you please share your screen, sir?
Yes, I'll share. Yes, can you see the screen?
Yes, sir. Yes, sir.
Okay. Should I start?
Yes, sir. Can you?
Okay. So good afternoon, everyone, and And thank you, the organizers, for giving me an opportunity to present a talk on hematopoietic stem cell transplant. Well, this is a topic that we work very closely, especially with the scenario in pediatrics at our institute in Noida. So this, as a part of this talk, I'll briefly take you through what is the concept of hematopoietic stem cell transplant, what is the pattern, what are the types, what are the global trends, what are the national trends, and what are the proposed suspected complication, both acute and chronic, and how do we manage them. So this is how I have outlined my presentation. I'll briefly talk about what are stem cells, what is the difference between stem cell therapy and a stem cell transplant, what have been the milestones, what are the regulations in our country that we need to take care, then finally coming to a bone marrow transplant, and then concluding it with some ethics in transplant. So as we all know, stem cells is a very unique cell which is present in our body and which has a capacity of self-renewal, and they can be differentiated in the terminal cell, whichever type of cell that we want. And there have been different type of stem cells which have been used for various clinical applications, which include totipotent, pluripotent cells. And there are some type of adult stem cells that are also prevalent in our bone marrow, which are usually used for treatment. So before we move ahead, we need to understand that what is the difference between stem cell therapy and stem cell transplant. So a stem cell therapy is use of stem cell, which can be any type of stem cell, to treat or prevent of a disease or a condition. And stem cell therapy has become controversial following the development of ability of the scientists to isolate and culture embryonic stem cells, which had a lot of ethical issues around it. So yes, there were a lot of applications and a lot of possible ways how stem cell can use and treat various type of diseases in our body, which you can see it on your right. But only established therapy of use of stem cell is hematopoietic stem cells, which are used to treat blood disorders, which are used to treat cancers, and some of the solid organ malignancies. So these are the only indications in which stem cells are proven to benefit. For rest of the stem cell therapies, one needs to go through a regulatory approval, a trial, and a study to prove that they are efficient. So when we go back to the stem cell transplantation, and this is the man who's called as father of the bone marrow transplant, he was, the first person to prove that the human bone marrow transplant gave a proof of concept that infusing a bone marrow can provide hematological reconstitution in a lethally irradiated patient with acute leukemia. And for this, he was awarded a Nobel Award in 1990. Following his work, there were a lot of other great scientists who worked towards the allogenic bone marrow transplant, where they used donors' cells to treat treatment of severe patients who had suffered accidental irradiation exposure and who survived with hematological reconstitution. And in 1963, they were able to successfully complete first engraftment and survival of a patient for over 1 year. Following this work, it made more clear that there has to be some matching between a donor and a recipient, and it came the importance of an HLA typing, where, if you're able to type these HLA antigens between the donor and the patient, there was a better outcome of these transplant. And since 1958, these antigens were being described. By 1968, we had some serologically molecular typing of these antigens. And, we were able to define that there is a disease called GVHD, which can occur if there is if the HLA doesn't match between the donor and the patient. And the first successful HLA match sibling transplant for a SCID patient was performed in 1968. So we all know HLA is a protein or a marker which is found on our body, and it is like an immune check cell which checks, whether a cell belongs to our own body or it is a foreign cell. And if in case it's a foreign cell, it generates an immune response to eradicate these foreign cells. So that is the reason we need to have HLA typing and matching, and even at times HLA cross match between the patient and the recipient. So if you see, just to briefly understand, if there is a couple who have around, 5 to 6 siblings, and there's a chance of around 25% match between the siblings, if they have 4 siblings. And if you see the patient and sibling 3, they are kind of completely matched between them, and they are good for a transplant in case if that is needed. Coming to regulation, so this was one of the most detailed document which came out through ICMR by our government in 2017, which talked about what are the national guidelines to do a research in stem cell. And this clearly states that hematopoietic stem cell is a treatment, is a present modality of treatment, and which does not need to undergo a research, which this documents talk about. And following this, very recently in 2021, there came the standards of doing a hematopoietic stem cell transplant, which talks about how, why, in which conditions, what are the other stakeholders, and how the patient needs to be treated, what are documents, what is the consent. All that was clearly defined in this document. And in India, if you're doing a hematopoietic stem cell transplant, which is as per the indications given by these documents, it doesn't need a separate approval. But if you're using some other type of stem cells for any other indication or disease, one has to go through this document and get a proper institutional, and if required, even the central committee approval to use these stem cells. Now, coming to bone marrow transplant, this is also referred at as hematopoietic stem cell transplant, or a stem cell transplant, or a blood and marrow transplant. So there are a lot of terms which are used to talk about the same thing. And when we see, it is basically a bone marrow transplant is a process which replaces the unhealthy bone marrow with a healthy bone marrow. So if there is a disease which is there in the bone marrow, we remove or we eradicate that bone marrow using a high dose chemotherapy, and we replace it with a new bone marrow from a donor. Now, they can be either autologous or allogenic. So when they are autologous, you use your own cells. So this is usually in cases where the disease may not be per se in the bone marrow. We remove the bone marrow, we preserve it, and then we do a high dose chemotherapy, like in a case of neuroblastoma. And then once the cancer is completely eradicated, we infuse back the same cell. So this is basically an autologous recovery of bone marrow. Whereas in an allogenic, we treat allogenic diseases where the disease is per se in the bone marrow, and we remove that bone marrow and replace it from a donor which has a similar HLA. Based on the HLA, there are different type of matching, which is like a sibling matched, where there is a 10/10 match between the sibling, and which is a preferred donor when we treat a thalassaemic patient. Another thing is going for a matched unrelated donor, which is the MUD, which we search for these donors through a lot of registries. We have few registries in India, and there are a lot of global registries which also participate, and help us find a MUD donor. And then there is a new concept, and now showing a good result, is haploidentical. So that is where you have a half match between the donor and the patient. And this is usually where where there's a single child, or where a single child can have, or a child can have a half match from their parent, and then the parent becomes their donor. So a bone marrow transplant can be used to treat blood cancers like leukemia and lymphoma, other bone marrow diseases like aplastic anemia, and other immune and genetic disorders like sickle cell anemia and thalassemia. So as far as the source of bone marrow stem cells is concerned, there are three main sources. First is the central source that we collect directly from the from the bone marrow, and using a wide bore needle. The second is from the peripheral blood, which we mobilize the donor and we collect these stem cells using an apheresis machine, or using the stem cell cord stem cells, which are collected from the cord blood, and which is from the placenta of a mother. So these are three main type of sources of the stem cells for bone marrow transplant that can be used. In a overall concept, if you see the first image, you collect the stem cells from a donor which has been mobilized, and then the patient receives a treatment to destroy the blood forming cells. That is, a heavy dose of chemotherapy is given to the patient, and once the cancer is removed, or once all the cells of the bone marrow are destroyed, the stem cells are received back to this patient to have the engraftment. If we briefly see what has been the global trend and the timeline, so we see, like from early 1950s and 60s, there was one of the first attempts to use bone marrow transplant to treat the radiational accident patient. Then there was the HLA grafting, HLA skin grafting experiments. By 70s, there were attempts to do allogenic transplant for leukemia patient. By late 1972, there was allogenic transplant for an aplastic anemia patient. Gradually, autologous was explored to treat lymphoma patients by late 70s. And then as we move ahead in 80s, there were attempts to treat sickle cell anemia and thalassemia using a bone marrow transplant. And now, as we went ahead from 90s, there was a lot of work which was done on, different type of regime which were used to customize the treatment or the transplant that we were doing. And depending on the case and depending on the matching between the donor and the patient, there were different drugs and regimes which were used. So if we see what is a trend in India, so this is a very interesting bar diagram which is supported and which is provided by the Indian Society of Blood and Marrow Transplant Registry. So this is a voluntary registry which is done in India and which registers most of the transplants that are done in our country. And at present, so this data is before COVID and it is till 2019. Till that time, 97 transplant centers were reporting their data, and more than around 20,000 transplants were done since 83 to 2019. So if you see in India from 1983, 84, 85, there were initial attempts to do a bone marrow transplant. And by 2019, there are nearly 2,500 transplants which are done across the country and reporting to this registry. So if you see the trend, what have been the allogenic versus autologous. So you see there were more amount of allogenics which were done. There are around 11,000 allogenics to 8,000 autologous which were reported to this registry. And if you see, there is a gradual trend of increase of these these transplant in our country. If you see the indications, so since 2012 to 2019, splitting between pediatric and adults, there were more adults which went into these transplant for registry. And in the adult, if you see the major chunk of cases which were done, there were myeloma cases, which were followed by, which were followed by lymphomas and AML and ALL, which had the major chunk of these disease. If you see pediatric had the major, burden of the thalassemia or the hemoglobin disorders, which were followed by the aplastic anemia, ALL, and AML. So these are the national trends of transplant and the indication of transplant, which is done in our country, both in pediatrics and in adult. Just to take you briefly through what happens in an autologous disease. So in an autologous transplant, we prime the patient himself to mobilize more stem cell in the peripheral blood, and we give either GCSF with or without chemotherapy. Once we have enough cells in the peripheral blood, which is usually around day 4 or day 5, we do an apheresis procedures to collect these stem cell and preserve them. And then we start the conditioning, and the conditioning includes a high dose chemotherapy which tries to kill the cancer which the patient is suffering from. And once we are sure that all the cancer is been eradicated, we reinfuse the same stem cells that we collected from the same patient. And then there is some aplastic phase which ranges around 2 to 3 weeks, and then there is engraftment of this bone marrow. So this is how an autologous hematopoietic stem cell transplants are planned. When we look at allogenic, so in allogenic, what happens is we treat this patient with a high dose chemo, and we start conditioning this patient. Parallelly, we collect stem cells from a donor which is pre-matched and which has a HLA similar to the patient. Then we infuse these stem cells from the donor to the patient. Then there is some 2 to 3 weeks or maybe at times 4 weeks of aplasia, which is followed by engraftment in cases of a successful transplant. Coming to overall how a transplant is planned. So, the day we infuse a stem cell is called day 0. And days before that are the conditioning days, where we try to treat the primary disease, which may or may not be in the marrow, using a high dose chemotherapy or a whole body irradiation. Then we do the infusion on day 0. either an autologous and allogenic, depending on the disease and the indication. Then there is an engraftment, which is the engraftment of the new bone marrow, and which is shown by the peripheral blood. And that is within 2 to 3 weeks, an engraftment is expected. But this period, when the patient is in an aplastic phase, there, he's at a high risk of infection. That is something to be treated. And then we have to look for GVHD if the patient undergoes a GVHD in cases of an allogenic transplant. And immunosuppression is very important if you're doing an allogenic transplant in these phases, and that is the key, and that is the most challenging part while treating these patients. Coming to a conditioning regime, so this is the first phase of transplant and may be given in one dose or over several days. It is necessary for suppressing the immune system to reduce the chances of graft rejection, destroying the remaining cancer cells, creating room in the bone marrow for the transplanted stem cells. Conditioning regime is dependent on the type of disease, the type of transplant, and the comorbidities in age. So there are different type of regimes and different type of drugs that are used. So if you see there is a beam regime, and if that is a standard regime which is used for these patients, and if you want to go towards low intensity, you use fludarabine and cyclophosphamide, and if you want a higher dose, you use a total body irradiation. So it depends which type of disease, which type of stage of that disease, the age of the patient, and that can help us, decide what type of myeloablative regime are we using. So a myeloablative regime is a high intensity regime where irreversibly which just destroys all the hematopoietic function of the bone marrow with a high dose of chemo or TBI. It gives us a high level of disease control. Younger patients do a good performance on these disease. There is a quicker engraftment because we remove the all autologous cells, and as expected, higher toxicities in this patient. Now, there is a growing interest of using a reduced intensity conditioning where we do not want to have such a high dose exposure to our patients, where it helps us to reduce the morbidity and mortality associated with allogenic transplant. It aims to use enough immunosuppression to allow donor cells to engraft completely without completely eradicating the recipient bone marrow. It can be given to older patient. It has less toxicities and reduced morbidity or mortality, which is associated with the transplant. Coming to a very important next aspect, which we from the transfusion medicine side has to work for, is the biopreservation of these grafts. So the transfusion medicine team has the responsibility of collecting, storing, and preserving these grafts that we collect from the bone marrow, which can be either central bone marrow or peripheral from the blood or even the cord blood. So the reason for biopreservation is, at times we need to ship these products. At times we find a compatible donor which is at the other side of the country or maybe the other side of the globe, and the product gets collected from there and gets shipped. So you need to preserve it. You need to preserve it to complete all safety and QC testing before the administration. At times, even to coordinate with these, with the patient regime. So in case of autologous, we collect these stem cells before, and then there is the conditioning which is given, and it takes around 10 to 15 days that the product needs to be stored with us. Then there are conditions where you plan a tandem transplant, which is one following the another. And in that case, also the products needs to be, or the graft needs to be stored. And then there's a concept of salvage transplant where we store some of the cells just in case we need to salvage our transplant patient. So biotherapy, I'll briefly discuss. There are two main concepts. One is the hypothermic biopreservation, or which is the cryopreservation. So hypothermic is you just want to store it for a few days, just for 2 days, and there is a short-term storage. You can store it at 2 to 8 degrees. It just reduces the cellular metabolism effectively for, it is friendly for a transport. But you need to do a cryopreservation when you're doing a long-term storage. It suppresses the biological function. It seizes the cellular metabolism. And, you can go up to minus 196 if you use a liquid nitrogen to store these stem cells. Well, there are a lot of regulations around it, and United States was one of the first countries to develop good regulations around the bone marrow transplant and stem cell. And the regulation for these transplant are published in Code of Federal Regulation under Title 21, part of 1271 of Federal FDA Federal Register. And they, classified the processing of these grafts into various sections. So 351 was, which was when, when you more than minimally manipulate the graft, and section 361 was when there was a minimal manipulation of these grafts. And they beautifully described what is minimal manipulation, which is 361, when you need to manipulate a product for an allergenic use. You don't combine the product with any device or drug except for sterilizing or preserving or storing, or storage agent. We do not raise a clinical safety concern. And the procedures which were enlisted in 361 were cryopreservation, cell selection, and plasma reduction. So these are very routinely done in any transfusion setup presently in India. Coming to 351, which is more than minimally manipulated, genetically modified, expanded ex vivo, which is used for more than, the other than normal function. It can be combined with a drug or a device. So it includes the ex vivo expansion, dendritic cell generation, and even the gene modification. So the new drug, which is the CAR T cells or the gene therapy drugs, all fall into the 351. So this is how United States split their product manipulation as per the FDA governance. Now, what is happening in India? So in India, 2021 guideline actually splits these regulation into three parts, which is minimal, more than minimal, and major. So in minimal, there is processing which neither alters the number or the biological function or characteristic of the cell. This processing includes simple isolation, separation, which we do using magnetic beads, washing and suspension in culture, decellularization, cryopreservation. So all that comes under minimal. Then coming to more than minimal is ex vivo alteration of these cell population, which is expansion, cryopreservation, cytokine-based activation. All this comes under minimal, more than minimal. But another thing which our document talks about is, you need to take several approvals if you work on more than minimal or major manipulation. So you have to make committees, which are institutional committees or the central committees under CDSCO, and all these procedure needs to get approval, and they need to be done as phase 1, phase 2, phase 3 clinical trials. So coming to some basic processing of the graft. So the key is to deliver the correct dose. At time, minimum dose and for an autologous transplant is 2 million cells per kg, and it can go up to 5 million cells per kg of CD34 cells in case of an haploidentical transplant. So we talked about HLA matching. We did not, considered ABO matching as one of the major challenges, since ABO matching is not something which is very necessary, since the ABO antigens are not there on the hematopoietic stem cell, the precursor cells. So if there is an incompatibility, which is there and very frequently in these cases, you can do an RBC depletion from the graft to avoid or to reduce the incompatible cells. We can do a plasma reduction in case of minor mismatches, and we can provide a low RBC content product for ABO incompatible. For cryopreservation, this is mainly to be done in India. That is done with autologous collection. DMSO is the most common cryopreserving agent which is used. These patients often, are kept with pre-medication. There is some side effects of using DMSO with, the alteration of blood pressure, bitter taste, and odor. Then allogenic infusion sometimes can need cryopreservation if they've been shipped from a distance, and the infusion should occur within 72 hours. So these are the common product manipulations which are done on the graft which is collected. So this is a very recent article in a study which we did pan India to study what is the trend of doing stem cell product manipulation across our country on the various stem cell therapy labs. So this was done last year, and we've had some very interesting results to it. So this was a survey-based study which we analyzed the basic demography. What is the type of product manipulation that they're doing? 110 centers received this survey, and 64 participated in this survey and completed the survey. So the survey ran from August to November 22 across the country. Most of the labs which participated were from Northern India. They were mainly from private sector. Most of the private sector is active in the HSCT arena. Then around 40% centers were doing more than 50 transplants annually. So this actually reflected what is happening pan India as far as the product manipulation was concerned, and majorly were done by the transfusion medicine team across the country. So there were 56 centers out of 64 which perform any one type of manipulation. Most of them were doing plasma reduction, RBC depletion, and up to 65 were doing cryopreservation. And as part of the study, we found there was a lot of variation in the way they were doing it. There were a lot of variation in the quality criteria, the release criteria used for these products. And there is an urgent need to develop a harmony between how we handle these products and release it for transplant. Coming to release, so once the patient is ready for a transplant, that is called as day 0, and it is these stem cells are, if cryopreserved, are thawed, or if they're fresh, are directly transfused to a patient using a central line, which takes around 30 minutes. And in case of cryopreserved products, there is a risk of side effect from the DMSO, and that is something that is taken care of. Now, how do we define engraftment that it has been successful since we have transplanted the patient? So if the neutrophil count is more than 0.5 10 to the power 9 for 3 consecutive days, or platelet engraftment is when the platelet count is more than 20,000 for 3 consecutive days without any transfusion support, is considered as the day of engraftment. So there are a lot of complications. So this disease has a lot of morbidity and mortality associated with this. So there's always a risk of infection since a lot of patients are immunocompromised, acute GVHD, conditions like hemorrhagic cystitis, hepatovenous occlusive diseases, capillary leak syndrome, diffuse alveolar hemorrhage, idiopathic pneumonia syndrome, and multi-organ dysfunction. So all this can happen in the early phases of transplant. It needs to be screened for and clinically examined for. GVHD is something which is very dreadful, seen in allogenic transplant. As classically defined, an acute GVHD is when it happens within 100 days. Skin, gut, and liver are the most common organs which get affected. Chronic GVHD is when it gets, after 100 days of transplant. And apart from skin, gut, liver, eye, lung, and connective tissues are the ones which also get affected. Risk for GVHD is prior history of acute GVHD, unrelated donor, mismatched transplant, male to female donor recipient, and old age. They can be prevented if we do a good HLA match, if we use a reduced intensity conditioning. There are some drugs which can be used, and even T cell depletion. So this is another thing that we use using some equipments where we use magnetic beads to remove the T cells, which are known to have a risk for GVHD. Once GVHD is set in, steroids, ATG, and even ECP, extracorporeal photopheresis, is used to treat. For late, there is a risk of chronic GVHD, late infections, pulmonary diseases, hepatitis, iron overload, back to work issues, late graft failure, relapse, sexual dysfunction, endocrine disabilities, cardiac failures, emotional issues. So there are a lot of other issues which needs to be, the patient needs to be in follow-up and see, if there is any late complication that needs to be managed. Coming finally to something which I feel is important when we talk about HSCT and usually is not considered adequately, is ethics when we are talking about bone marrow transplant. So all stem cell related research or trials need to undergo 2 levels of monitoring, which is one is the institutional committee and the other one is the national committee or the national apex committee. And then if you're doing a transplant for approved indication, that doesn't need a trial approval. That is an approved therapy. And how do we know which disease? So ICMR has given us a good elaborate list of diseases, both for adults and pediatrics, in which the hematopoietic stem cell transplant is approved therapy and it can be used and doesn't need a special approval as a trial. So there are a lot of diseases, both in adult and pediatric, which are approved. As far as outcome in pediatrics is considered, this was a 2011 data, which shows around 80% survival, 85% survival if you have a related donor in case of aplastics, whereas it can go as low as 20% in most of the diseases. So it depends what type of donor, what type of transplant, whether it's the disease is early, intermediate, in remission and not in remission. So it's an advanced disease. So that is something which has a huge difference. Another thing that we need to take care is the risk and benefits when we are taking the stem cell from a donor. We should know that there should be adequate discussion whether we are not putting the donor at any risk when we are taking stem cells, and especially in dealing with pediatrics, something that we do in Noida, taking parental permission, donor assent is very important. Coming to risk versus benefits, we need to explain it to the patient what are the short-term and long-term outcome risks and benefit depending on type of disease, stage of disease, relationship between donor and the recipient, degree of match, type of conditioning regime, and what are the risk of infections and GVHD. Now there is also concept of savior sibling, when using the assisted fertility techniques like in vitro fertilization. You plan a savior sibling where you don't have a matched sibling with you, and you can do a pre-implantation genetic diagnosis of what kind of genes that you're looking for, and you can use the umbilical cord cells. So even doing that, there is a lot of debate of merits and demerits of this approach. Then again, decision making is complex. It needs to be taken care ethically, legally, and clinically. We have to take all these aspects. Dealing with children are difficult. Their parents need to have complete counseling and discussion of all the possible side effects, and because it's a longer treatment, it's a longer plan that all needs to be discussed. Socioeconomics. So when can you offer? This is an expensive therapy, although Government of India is planning to bring it under the Ayushman Bharat scheme, but it's still one of the most expensive therapies, and using expensive drugs, long hospital stay, and very long follow-up, all that needs to be discussed. So our experience from PGI Noida, we started bone marrow transplant 2019. We started with a single bedded BMT, and now very recently we have started work with the 8-bedded pediatric BMT, and which should get inaugurated within a month. And that probably will be one of the biggest pediatric BMT center in the government setting in the North India. Presently, we have completed 29 transplant. We have done more than 30 collections, peripheral stem cell collections. We are doing all autologous, allogenic, haploidentical, and we have also validated and are using in-house cryopreservation protocols. And we have done it for our nearly 10 products, and all the patients engrafted and are doing well. Finally, to conclude, the cruelty. So it is a cruelly ironic that the genesis of BMT grew from an unprecedented capacity of destruction and harm caused by the atomic bomb. And for in many ways, the history of BMT closely parallels the ethical and the clinical journey of child and parent and pediatrician must navigate through in the landscape, filled with uncertainty and laid bare by the promise of cure and the potential of great harm. So there is always a risk of harm and cure, and we have to balance it out. And the ethical dilemma when we're doing a transplant is there in front of as a medical dilemma in its purest form. Thank you. Thank you for your patient hearing. I'll be happy to take some questions.
Dr. Satyam, that was a wonderful session. Thank you for enlightening us.
Thank you, ma'am. So yeah, we have one question in the chat box which says cryopreservation. So see, we do cryopreservations to we have one case of neuroblastoma which we have done it last week. As the patient was in remission, they were planned for an autologous transplant, and we have collected the stem cells 10 days before the scheduled transplant. And when we have collected, we can only store these stem cells for 1 to 2 days at 2 to 8 degrees. Once you have to store them for more than 2 days, you need to cryopreserve these cells. And we do a cryopreservation using DMSO, HES, and albumin. And we have stored them using a dump freezing method, which is using a -80 freezer. And once the conditioning is complete, the patient is completely eradicated of his own bone marrow and the tumor. The same cryopreserved cells will be thawed and transfused to this patient, probably in a gap of 10 to 15 days, and we look for engraftment. So that is where you need cryopreservation. Cryopreservation is also needed if you want to ship your product. So if you have a donor, if you're doing an HLA matching, and if you have a donor maybe in Delhi and the patient is in Chennai, so if either the donor can travel over there, or if the donor doesn't travel, we collect stem cells, we store it, cryopreserve it, and then once we have the product in our hand, then they do the conditioning with the patient in Chennai, and once that is ready, we ship the product to them. So that is to streamline between the treatment regime and requirement of the stem cell product. Since we can't store the stem cell product for more than 2 days at 4 degrees, we need to cryopreserve them. And if we want to do it for longer time, for like 8 years, 10 years, or maybe 20 years, we need to use liquid nitrogen with a temperature of minus 196, which usually people do for umbilical cord storage. That is a long-term cryopreservation using a DMSO of around 5 to 10%. I hope I'm able to answer Dr. Indira's question.
Thank you, sir. No, can we preserve for 7 days, sir?
So yes, there have been a study where
for lymphoma.
Yes. So there have been a study at PGI Chandigarh where they kept the product at 4 degrees for 7 days, but there was a drop of around 65 to 70% of the viability. So the viability was
minus 80 if we can preserve.
Yeah, we can preserve. So if you want to do a minus 80 preservation, you need to do a cryopreservation. You need to use DMSO, HES, albumin, and there are different type of cocktails which are available in the market.
So do you have a procedure for that, sir? You have
Yes, we have a procedure. We have also published it. And we have a follow-up of nearly 50 patients. That was from the previous institute. I'll just maybe put it up in the chat box.
Okay, sir.
The link, and we are doing it regularly in Noida as well.
Okay, sir.
So I'll just put our publication
okay, sir. Thank you so much
in the chat box. Thank you.
Okay, sir.
Thank you, sir. For further questions, you can answer in your chat box.
Thank you. And I've just put it up the link for the article, which is free to access article. Thank you.
Now next, Richa Gupta.
Yeah, you have to enable the share screen option for me.
Yes, ma'am. Wait a minute, ma'am. Can you please share your screen, ma'am, now?
Yes. As that screen is visible?
Yes, ma'am.
Is my screen visible?
Yes, ma'am.
Okay, just a moment. I just wanted to make it in the PPT mode.
Ma'am, you have to download it first.
No, it is downloaded. It's just downloaded on my desktop.
Ma'am, it's in your taskbar. Please open. No, ma'am, not this one. Other one. Ma'am, please see your taskbar. Yes.
This is my.
You have to click on this.
Okay, just hold for a minute.
Ma'am, please download the PPT.
It's already downloaded and I've minimized it. It's minimized. I'm just maximizing it, but I can't see how to.
Ma'am, you can see your WhatsApp in your taskbar.
Okay.
Ma'am, you can see your WhatsApp in your taskbar.
WhatsApp in the taskbar. Yes.
Yes. Move Excel. You can see Excel.
No, just wait a minute. Wait a minute, please.
Yes, ma'am. Click.
In all studies. So theoretically, your patient population and your intervention should be similar across the studies, which is in real life clinical scenario impossible. Someone use a 20 ml drug.
Okay, shall I start?
Yes, ma'am. Your time start now.
Okay. So good afternoon, everyone. This is the second last presentation of today, and I think it's been a busy Sunday for all of you. And I am actually out for a Sunday and just taking my presentation from there. So it pains me the same as you. So let's begin. And it's a very basic presentation. I'm just trying to enlighten you a little bit about immune hemolytic anemias. And now, why is it not moving? Okay. So my talk is about immune hemolytic anemias. I'll be covering just the basic things, and in the next 20-25 minutes, I would be just talking about the basic things about immune hemolytic anemias and how the workup of immune hemolytic anemia should be undertaken, both alloimmune and autoimmune. So what is immune hemolytic anemia? Simply said, it is just the immune-mediated red cell destruction by any antibody, and because of the antibody, it can be a complement, which finally leads to anemia. So we know there are two sites where the red cells can be destroyed. It can be extravascular, it can be intravascular, and in many conditions, you get both intra and extravascular hemolysis. Now, whether the patient is going to develop anemia and what severity of anemia is it going to be will depend on how severe the hemolysis is and what is the ability of the marrow to compensate for this level of hemolysis. So normally, we all know that our marrow can compensate up to 5 to 8 times. But if the hemolysis is more than that, then definitely there will be anemia. And if the hemolysis is very brisk, for example, in some cases of cold or in cases of paroxysmal nocturnal hemoglobinuria, then we can get a very severe paroxysmal cold hemoglobinuria that occurs in children. We can get a very severe brisk intravascular hemolysis. So here you get a very rapidly developing anemia. Now, as I told you, there can be two sites of hemolysis. You can have an extravascular hemolysis or you can have an intravascular hemolysis. So extravascular is much more common, and here the red cell gets opsonized. You know what opsonization means? That the antibody or the complement gets attached to the red cell surface, and that red cell is picked up. The receptors for the antibody or the complement are present on the surface of the red cell, on the macrophages present in the spleen and liver. Specifically, the macrophages of spleen, they have an Fc gamma receptor for IgG, and the macrophages there on the liver have a receptor for C3b. And that is how these macrophages would either pinch a part of the RBC membrane, which leads to formation of what we all know is a spherocyte, right? So a spherocyte is a telltale sign of an extravascular hemolysis. The other type of hemolysis which we can encounter is the intravascular hemolysis, where the antibody is capable of fixing complement. So when we say fixing complement, we mean that the complement cascade gets activated. Beyond C3b and A, we also get formation of a membrane attack complex. So there's a terminal complement activation, which leads to a red cell lysis. Now, not all antibody groups can cause this kind of complement activation. The groups of antibodies which produce this kind of complement activation can be IgM most commonly, IgA sometimes, and out of the G1 to G4 type of IgG antibodies, in general, there's a dictum that IgG antibodies do not fix complement, but G1 and G3 very well can fix complement and produce intravascular hemolysis. This is what we see when there are these IgG antibodies specifically to the ABO blood group. So just a recap, we all know this is very, very basic. We all know that IgM antibody is called a cold antibody because it has a reactivity between 4 to 20 degrees centigrade. That's the thermal amplitude. And higher would be the thermal amplitude, more pathogenic the IgM antibody is going to be. It is large, it's a pentamer, and that is why it is capable of agglutinating the RBCs in a saline suspended medium. And that is what we mean by a complete antibody. So IgM is a complete antibody, while IgG has maximum reactivity at 37 degrees centigrade. It's a small antibody relatively. And since it's a small antibody, it cannot bring the red cells so close that they can agglutinate, because there would be a negatively charged on the red cells and they will start repelling each other when they come so close. So IgG is an incomplete antibody. It needs some kind of assistance so that you can actually observe that there is an IgG which is coating the red cells, or it can produce agglutination. So because of its characteristic of activating the complement, fixing the complement, the IgM can cause intravascular hemolysis, while IgG antibody usually does not cause it. It's the writer is usually, because we know that G1 and G3 group can cause intravascular hemolysis. Now, if this is again a diagram which shows you how IgG and IgM mediated hemolysis occurs. So if you see IgG, what happens is that the most important mechanism by which it produces hemolysis is that the IgG is capable of coating the red cell, and that's what is opsonization or sensitization. And these receptors are there on the macrophages which recognize the IgG, and therefore the mechanism of hemolysis in IgG mediated hemolysis is basically an extravascular hemolysis which is occurring in the spleen. Also, the IgG, when it combines with here on the red cell, it causes the complement cascade activation, and you get formation of C3b. Now, the C3b can be recognized by macrophages on the liver. So also liver is another site of extravascular hemolysis, both in warm and cold type of autoimmune hemolytic anemias. And sometimes, rarely, this C3b can finally lead to formation of a membrane attack complex, and here you get an intravascular hemolysis. So out of these three mechanisms, the spleen, the liver, and the intravascular, the most important mechanism of the IgG-mediated hemolysis is the hemolysis occurring in spleen. While IgM, if you see the IgM-mediated hemolysis, what happens? IgM is a large antibody, and normally the antibody would not stay on the red cell surface. What would stay on the red cell surface is the complement products, that is C3b. And as I told you, the C3b is recognized by the macrophages on the liver. So in IgM-mediated hemolysis, the main site of extravascular hemolysis is the liver and not the spleen. Also, because IgM is more efficient in fixing the complement, it causes formation of this membrane attack complex, and there is intravascular hemolysis. So another recap, what happens when there is extravascular hemolysis? The hemoglobin is released, or the heme is released into the reticuloendothelial system. Okay, it's not released directly into the circulation. And because it is released into the reticuloendothelial system, it gets formed into unconjugated bilirubin over there. And this unconjugated bilirubin, depending on how much is formed, is conjugated in the liver and is extracted as urobilinogen into the feces and urine. So whenever there's going to be extravascular hemolysis, you will get hyperbilirubinemia, mainly of the unconjugated type, and you will get a lot of urobilinogen in the feces and urine. While what is happening here in intravascular hemolysis is that the hemoglobin is being released within the circulation. So what is the protein which binds hemoglobin in the circulation? It's haptoglobin. So you get the haptoglobin gets consumed. So if you do a haptoglobin level, it will be low. There will be hemoglobinemia. Some hemoglobin will be released by the kidneys. So there will be hemoglobinuria. Also, there will be formation of hemopexin and methemoglobinuria. So these are all the conditions which you see in intravascular hemolysis. Now, recap about the direct antiglobulin test. What does it do? It detects the presence of the incomplete antibodies on the surface of the red cell. So if the red cell has an IgG coated on its surface, or if the complement is there on the red cell surface, they themselves will not agglutinate the red cells. Okay. So if you see these saline suspended red cells, they do not agglutinate on themselves. So what do? You add an anti-human globulin, which is directed either against IgG or it's directed against the complement, and that is capable of producing an agglutination reaction. So that is the basic concept of a direct antiglobulin test. What does it do? It basically confirms that the hemolytic anemia you are dealing with is immune in nature. So it only confirms the immune nature of the hemolytic anemia. Now, when I talk of direct antiglobulin test, it is commonly known as the Coombs test. The Coombs reagent, it can be polyspecific or monospecific. Polyspecific matlab, it contains both IgG. So IgG basically is going to be the one which is going to be there in the warm type of autoimmune hemolytic anemia, right? And it also has C3d or C3b. These are the ones which will be there when there's an IgM-mediated hemolysis, because IgM does not have an amplitude up till 37 degrees centigrade. So it detaches from the cell when the temperature gets warmer. The only telltale sign of presence of an IgM is the complement production, right? The other type of Coombs reagent is the monospecific Coombs reagent, which will have either IgG or C3d. So whenever you have established that, yes, you're dealing with an immune type of hemolytic anemia, you want to further see whether it is warm type or cold type. So you use a monospecific Coombs reagent. Now, there's an important word of caution here that most of the Coombs reagent which we commercially use, they do not contain IgA or IgM directly. So if there's an autoimmune hemolytic anemia which is occurring due to IgA, your Coombs test is going to miss it. And this is one of the reasons where you can get a false negative Coombs test despite of having an autoimmune hemolytic anemia, right? Now, the autoimmune that or the direct antiglobulin test can also be negative if the antigen density on the cell surface is very low, because most of the conventional Coombs reagent, they cannot detect an antigen density below 150 to 200. So if the antigen density is low, then also you can have a false negative Coombs test. And what is the condition where you can have a false positive? There are several conditions where the Coombs test can also be, especially the mild uh, level of TCT may be positive. This can be seen in patients with hypergammaglobulinemia, for example, liver diseases, renal diseases, certain cancers. They all can give you a false positive Coombs test. So it is important that a DAT is only read whenever there is some kind of, when you've established that, yes, this patient has hemolysis. So in the light of that, you can do a DAT. But if a DAT only is positive, that does not say that the patient has a immune hemolytic anemia. It has been seen that 8 to 10% hospitalized patients do have a mild DAT positive, right? And if there's a false negative DAT and you still have a high suspicion, you can go on and do a more sensitized type of direct antiglobulin test, which can be an extended DAT or a flow-based DAT. So how do you classify immune hemolytic anemias? They can be classified simply. It's a very simple classification. The autoimmune ones, where the patient has an autoantibody, right? And the other type of immune hemolytic anemias can be the alloimmune hemolytic anemia, where there's a foreign antigen against which the patient develops an antibody. And the third broad category is the drug-induced hemolytic anemia. Now, why it is important to recognize that which type of immune hemolytic anemia is the patient having, because the specific treatment can only be given then. It's not the same for both autoimmune, warm or cold type, or alloimmune, of course. So coming on to autoimmune hemolytic anemias, the patient has an autoantibody which is reacting against patient's own red cell antigens. It can be a warm type of autoimmune hemolytic anemia. It can be a cold type of autoimmune hemolytic anemia. And sometimes it can be a mixed type where you have both warm reacting and cold reacting autoantibodies. Now, the pathogenesis of autoimmune hemolytic anemia is similar to other autoimmune diseases. The patient would have a genetic predisposition, and there would be certain infectious agents by way of molecular mimicry or some other mechanism. They induce autoimmunity, and there have been seen defects in T cells, especially the T regulatory cells in these patients. Now, the warm type of autoimmune hemolytic anemia is the more common one. It accounts for around 70% of these cases. And remember that in warm type of autoimmune hemolytic anemia, the antibody is a polyclonal IgG, all right? It's usually a polyclonal IgG, which has an optimal reactivity at 37 degrees centigrade. That is why the name warm type of autoimmune hemolytic anemia. But sometimes the antibody can also be an IgM and rarely an IgA antibody. Now, most of these antibodies would be directed against the Rh protein complex, okay? So they would agglutinate all RBCs which are Rh positive. So remember, I'm saying Rh positive, I'm not saying D positive, right? So all the Rh protein, there are many antigens in the Rh protein complex, and these antibodies are directed towards these antigens, and that is why they are known as pan-reactive. So the only cells where these antibodies would not react with are the Rh null cells, where the Rh protein is totally absent. Now, 50% of warm type of autoimmune hemolytic anemias are primary, and the rest are secondary. Primary, means that you do not find any underlying disease, while secondary warm type of autoimmune hemolytic anemias can be associated with a lymphoproliferative disorder or an autoimmune disorder, certain viral bacterial infections, rarely neoplasias, and some vaccines also can give rise to secondary warm type of autoimmune hemolytic anemias. Now, how do you make a diagnosis? Usually, they can be a variable age group, but generally the incidence increases and is more common in elderlies. The common presentations can be symptoms arising due to anemia, fever, fatigue, or a transfusion requirement due to a rapid fall in hemoglobin. Then if there's a secondary kind of autoimmune hemolytic anemia, you'll get a sign and symptom of the underlying disorder, maybe an autoimmune disease or a viral bacterial history of a viral or a bacterial infection. And obviously, what is the main site of hemolysis in a warm type? It's the spleen. So these patients would generally show splenomegaly, and there is some hemolysis which can occur in the liver also. So there will be some hepatomegaly also. because of the hemolysis as well as the extramedullary hematopoiesis occurring in the liver and spleen. Now, what will be the lab findings? So the first thing you need to do is to establish that there is hemolysis. How will you do that? We just discussed that there would be a fall in hemoglobin. So a fall in hemoglobin more than 1 gram% in a week is definitely a feature of hemolysis and not a nutritional type of anemia. An increase in bilirubin and unconjugated hyperbilirubinemia, urobilinogen in urine, fall in hemopexin, and reticulocytosis. Now, reticulocyte would count because the marrow is going to react, so there would be reticulocytosis, but that's not necessary. Some of these patients may have reticulocytopenia also. Now, what are these set of patients which will have reticulocytopenia? Suppose the antibodies are not just against the RBCs, but they are also killing the RBC precursors in the marrow. So these patients would not show you a concomitant increase in the reticulocytes as you would expect. Or maybe there's an underlying disease right there in the marrow, a lymphoproliferative disorder, or in some autoimmune diseases also, you see that the RBC precursors, they get depressed. Okay, so reticulocytosis is not necessary in all cases. And another evidence of red cell hemolysis can be the presence of spherocytes and schistocytes if there is an intravascular hemolysis. The next step is to establish that there is an immune-mediated hemolysis. So you do a DAT is positive, you go on to a monospecific DAT. Even if the polyspecific DAT is negative and you have a high suspension of an autoimmune hemolytic anemia, you go on to do a monospecific DAT, which shows you they can show you presence of IgG, C3d, and rarely an IgA. Then an antibody screen will show you an antibody screen will be reactive with all cells uniformly because this is an autoimmune type of hemolytic anemia, and the auto control, which is usually done with the antibody screen, will be positive. Then the third thing is to rule out all secondary causes. That is, you take a proper history, do a clinical examination. To rule out an autoimmune disease, you can do an anti-nuclear antibody and other serological markers, viral markers to rule out viral diseases, and also peripheral blood you see atypical cells, and you can do a flow cytometry if you are suspecting a lymphoproliferative disorder. Those are the tests which can be done to rule out secondary causes. So what is the treatment of warm type of autoimmune hemolytic anemia? So the mainstay of warm type of autoimmune hemolytic anemia treatment is corticosteroid. So that's the first line therapy, which is used in all these patients. The second line therapy is rituximab. We all know it's a monoclonal antibody, which is directed against CD20. It is generally not used as a first line therapy in these cases, except when you're dealing with an atypical case. Suppose you're dealing with Evans syndrome, you're dealing with a severe case, you're dealing with a refractory case, then you go on to add rituximab. And other options like splenectomy, that is not discouraged these days because there is a lifelong prophylaxis against, the patient needs antibiotic, lifelong prophylaxis against certain infections, and there is a high risk of thrombosis. So splenectomy is not something which is considered at first line. Rather, there are immunosuppressive drugs which may be considered for such patients who do not respond to steroids and rituximab. So then we come on to cold type of autoimmune hemolytic anemia, which is the less commoner type amongst the two. This is due to presence of cold agglutinins, which have a high thermal range. Okay. So normally a patient may have a cold. What do you mean by cold agglutinin? It's a cold autoantibody which is capable of agglutinating the red cells. Okay. And normally these cold agglutinins or the cold autoantibodies, they are just reactive at below 10 degrees centigrade. But if there is a cold agglutinin which shows you a reactivity which is above 30 or 32 degrees centigrade, then it becomes a pathogenic cold agglutinin. The antibodies in this case are generally directed against the I blood group system. For warm, we had the Rh proteins. Here we have the I blood group system, the capital I antigen. So again, we can have a primary cold agglutinin disease when you do not get any underlying disorder. But most often it has been seen in these patients that a primary cold agglutinin disease is usually there is an association of a monoclonal antibody, a monoclonal IgM, as a part of an underlying lymphoproliferative disorder. So now it has been found retrospectively that all those patients who were reported, or majority of patients who were reported as primary cold agglutinin disease actually had a lymphoproliferative disorder. And with that, you'll have a monoclonal antibody, and usually it's an IgM. If there is a secondary cause, we call it as cold agglutinin syndrome, and generally it is associated with specific infections, especially mycoplasma, Epstein-Barr virus, cytomegalovirus, and it has also been seen with COVID. Then there can be cancers and lymphomas, which also can give rise to a cold agglutinin syndrome. So what will be the clinical findings here? Here the patient can show you a chronic or an episodic hemolytic anemia, which is exacerbated after a cold exposure. Okay. So all those areas which are exposed to cold, there can be an RBC agglutination, and therefore you get these vascular changes like acrocyanosis and Raynaud's phenomena in these patients. Also, there is a lot of it is mediated by IgM, and therefore we have an intravascular hemolysis. So the patient can tell you about hemoglobinuria, hepatosplenomegaly, and because of a lot of hemoglobin being secreted, there may be, in some rare cases or severe cases, you can get an acute renal failure also. So again, what will be the lab findings? Again, you have to first establish that yes, there is an ongoing dead cell hemolysis by same things. Apart from that, because there is a large component of intravascular hemolysis, you can also get hemoglobinemia, hemoglobinuria, and methemalbuminemia. Reticulocytosis, sometimes reticulocytopenia. Then in peripheral blood, here you will find more of schistocytes and less of spherocytes. And sometimes the RBCs agglutinate together. So the RBC MCV may be falsely high in these patients because of the RBC agglutination, which can be seen on the smear. Then to establish the immune-mediated cause of hemolysis, you do a polyspecific DAT followed by a monospecific DAT where you see C3D. So the presence of C3D alone does not prove that this is a case of cold autoimmune hemolytic anemia. You have to go on and do a cold agglutinin titer. So only if the cold agglutinin titer is above 64, okay, then only you can establish a diagnosis of cold type of autoimmune hemolytic anemia, because C3D can also be seen with a warm type of autoimmune hemolytic anemia. So you have to go on and do a cold agglutinin titer, and an antibody screen will again show you a reactivity with all cells uniformly. So what is the treatment of cold type of autoimmune hemolytic anemia? Generally, these cases are less severe and less symptomatic. So the conservative management is one which is advised, that protect the patient against cold, and occasional transfusion support may be needed. And it is said that the patient should be kept warm, and even if the transfusion is given, a blood warmer can be used in these cases. Treatment is only reserved for those cases where you have symptomatic anemia or transfusion dependence. And important thing to remember is that steroids are not the mainstay of therapy. They should not be used. Rather, rituximab is the mainstay of therapy, and it can be combined with several drugs now which are under use. So the third type of hemolytic anemia is the mixed type of hemolytic anemia, which well as cold reacting IgM antibodies, both in high titer and increased thermal amplitude. Now, 50% of these cases are again idiopathic, and remainder may be associated with a lymphoproliferative disorder or an autoimmune disease. And you find both intra and extravascular hemolysis. The good thing is that most of the cases of mixed type autoimmune hemolytic anemia are not that severe, and most of these patients will respond to steroids without the need of transfusion. So the next type of autoimmune hemolytic anemia is the paroxysmal cold hemoglobinuria. Now, this is a rare hemolytic disorder which is seen usually in children below 5 years of age in association with a viral or a bacterial infection. Generally, there is a massive intravascular hemolysis and hemoglobinuria. And these patients, there is a biphasic hemolysin, which is known as the Donner-Landsteiner antibody. The antibody, it binds to the RBCs at low temperature, fixes complement, and lyses the cells when they rise up to 37 degrees centigrade. Now, here the direct antiglobulin test will only be weakly positive for complement, and a cold agglutinin titer will also be negative. What are you going to do next is the Donner-Landsteiner test, which will be positive. And it is seen that the C5 inhibitor, eculizumab, has been shown to be of use, very useful in these patients of PCH. These patients respond very well to the C5 inhibitor, eculizumab. So then we come to the second type of immune hemolytic anemia, that is the alloimmune hemolytic anemia. Now, this is obviously due to an allo antibody which is directed against a foreign RBC antigen which the individual himself lacks. Now, the two main causes are incompatible transfusions or hemolytic disease of the newborn. Obviously, a hematopoietic stem cell transplantation can also give rise to an autoimmune hemolytic anemia, but that's an uncommon cause. Now, here, the cells do not react with the individual own RBC, so the auto control is going to be negative. And what are you going to get? You get a pattern in the antibody screen. You do an antibody screening with a 2 or 3 cell panel, which comes out to be positive. Now, The hemolytic transfusion reactions are more commonly, obviously, we all know that they are seen with the ABO blood group because they are the most immunogenic, but they can be seen with other blood groups, including the RH, KL, Duffy, especially when the patient has been multiply transfused. And most often you see them with red cell transfusions, but sometimes they can be some amount of mixing of the red cells with the product. So if 0.2 ml, say, Zada red cells are given in any product, they can very well cause an immune-mediated hemolysis. And the diagnosis can be confirmed by, obviously, there should be a temporal relationship. There should be that the patient develops, post-transfusion, the patient develops fever, chills, and hemoglobinuria. And a post-transfusion DAT should be positive. In that case, you also have to have a pre-transfusion DAT, which should have been negative. And an incompatibility between the patient's blood group and the donor blood group can be confirmed on repeat testing. Most often it is due to a technical error. These are the immediate type of hemolytic reaction. You can also have a delayed type of immune-mediated alloimmune transfusion reactions due to an agonistic response, and which are seen to RH, KED, Duffy, KL, and MNS blood group systems. So what is the workup of hemolytic transfusion reactions? You first have to rule out all other causes of non-immune hemolysis, that the blood warmer was not used. There is no cause causing mechanical. The BT set which was used for transfusion was a proper BT set. There was no sepsis. All these things have to be ruled out, and the blood bag along with the fresh patient sample and the first void urine sample is collected, and you proceed with a clerical check. You first reconfirm the identity of the patient, reconfirm that there was no such thing as wrong blood and tube, and the bag was also labeled correctly. You check the blood group of the patient as well as you check the blood groups written on the bag as well as on the patient sample. Then you do a visual check that the urine for hemoglobin is not pink in color. The serum or plasma is also not pink because of hemoglobin. Does the bag contain any clots or discoloration? And you make a peripheral smear and see whether there are schistocytes, which is a telltale sign of intravascular hemolysis. After you've done a clerical check, you've done a visual check, you go on to do a serological test. You repeat the APO testing with the patient's pre and post transfusion sample. You repeat a cross match with patients of the donor with the patient's pre and post transfusion sample. And you do an antibody screen on the new sample and a direct anti-globulin test on the patient's fresh sample. So all these will establish that whether there has been a hemolytic transfusion reaction or not. Then obviously we all know what a hemolytic disease of fetus and newborn is. There is an immune-mediated destruction of fetal red cells which occur due to maternal antibodies due to previous exposure. The diagnosis includes that the mother sample's ICT should be positive, that there can be neonatal hyperbilirubinemia or a fetal anemia, which can be confirmed by several methods. Then this can usually is due to an RH incompatibility. The D antigen we all know is very well implicated, but other antigens belonging to the RH blood group system or other minor blood group system antigens like M, S, and KEL have also now found to be causing a lot of cases of hemolytic disease of the fetus and newborn. ABO incompatibility is much more common, but generally does not cause hemolytic disease of fetus and newborn because the ABO antigens get diluted. They are present on several cells except apart from the red cells. So generally you do not find so much HDF arising due to ABO. Now, then we come to the drug-induced hemolytic anemias. Now, these are occur due to immune responses due to drug-induced alterations of the RBCs. They can be classified as drug-dependent and drug-independent. Drug-dependent, when the drug in itself alters an RBC membrane, it combines, it is there, and it causes an alteration in some part of the antigen which the body starts recognizing as new. And drug-independent, when the drug does not go and bind there, but it just causes an alteration without even the drug being there. Okay, so that's the drug-independent type. Many drugs have been implicated. We know that penicillin and alpha-methyl-dopa were the ones which have been historically talked about, but now cephalosporins and NSAIDs are the ones which are causing more cases, especially ceftriaxone. So cephalosporins and NSAIDs can cause drug-induced hemolytic anemias. Treatment is usually supportive. Withdrawing the drug is one obvious part which we are going to do, but it will be more useful in the drug-dependent type of drug-induced hemolytic anemia, not in the drug-independent type. And this has to be differentiated from drug-induced non-immune hemolysis or a spontaneous autoimmune disorder. So finally, just a recap about the workup of immune hemolysis. What do you do when you get a patient? So the first thing is to see the clinical presentation of the patient. If the patient can present with anemia, features of hemolysis, so you have to see the clinical presentation, hepatosplenomegaly, the clinical examination. Then you confirm that yes, there is an hemolysis which can be documented by rapid fall in hemoglobin rise in unconjugated bilirubin and LDH, reticulocytosis, hemoglobinemia, and hemoglobinuria. So first you see the clinical presentation, you confirm, yes, there is an hemolysis. Then you rule out other causes of hemolysis depending on the age of the patient, whether there's a G6PD and an enzyme disorder possibility or hereditary spherocytosis. All these have to be ruled out. Gilbert syndrome can also give rise to unconjugated hyperbilirubinemia. Once you've ruled out other causes, you take a proper history that whether this patient has a congenital problem, whether there is another sibling in the family which has a similar history, any history of recent infections, any history of recent drug intake, and the investigations, the basic preliminary investigations which you need to do is a CBC, obviously, a peripheral smear, a urine examination, and obvious other investigations to rule out causes like hereditary spherocytosis, an OFT, a G6PD, and a flow for paroxysmal nocturnal hemoglobinuria. So once you've ruled out all other causes and you are thinking in terms of a direct antiglobulin test, then what you need to do is a polyspecific direct antiglobulin test. So if your polyspecific DAT is negative, then most likely you are not dealing with the immune hemolytic anemia. But if you still have a high suspicion, you repeat the DAT with a more advanced technique. However, if your polyspecific DAT is positive, you can very well say, and it was negative previously, and you have an evidence of hemolysis occurring in the patient, you can say that, yes, this is immune hemolytic anemia. The next step is to see whether it is alloimmune or autoimmune. Drugs you've already ruled out. So to establish whether it is an alloimmune cause or an autoimmune cause, obviously the history is very, very important. Pregnancy will be obvious. And if the patient has taken anti-D, you will know, and the history of transfusion. Then the other two investigations which are important are the antibody screen panel and an auto control. So an antibody screen panel, usually in cases of autoimmune hemolytic anemia, is positive, while in alloimmune hemolytic anemia, it shows you a dosage or a pattern effect. Okay, the auto control is negative in cases of an autoimmune in alloimmune hemolytic anemia, while it is positive in autoimmune hemolytic anemia. So once you've seen that DAT is positive, you go on further, you get a monospecific DAT done. If it is only showing you an IgG and not C3D or IgM, you can say with some confidence that you are dealing with a warm type of autoimmune hemolytic anemia. However, if the IgG and C3D both are positive, or only if the C3D is positive and IgG and IgM are not so much positive, then you do a cold agglutinin titer. If it is more than 64, yes, you are dealing with a cold agglutinin disease. If it is not, then you still stay on to the diagnosis of a warm type of autoimmune hemolytic anemia having both IgG and C3D. If the cold agglutinin titer is also above 64 and IgG was also there, then it's a mixed type of autoimmune hemolytic anemia. And if just the cold agglutinin titer is high without the presence of IgG, then it is a cold agglutinin disease or a cold agglutinin syndrome. You have, in that case, you have to do the workup to see if there's an underlying disease. If you find an underlying disease, you can say it's a cold agglutinin syndrome. And if it is not, then also you have to do a bone marrow evaluation electrophoresis to rule out the presence of a lymphoproliferative disorder. So I think that's all for today. Thank you so much. I'll be happy to answer any questions. Yeah, Dr. Indira has written something in the chat box.
Yes, ma'am.
DAT negative. Sorry, I can't read this chat box. What have you written, Dr. Indira?
It's that negative and ICT positive. What do you think of, madam?
So if it's
That
ICT,
sometimes ICT positive and that negative sometimes comes.
yeah, so if the ICT is positive, you go on to do also a titer of what is the ICT titer positivity, right? This case you are telling in terms of a hemolytic disease of the fetus and newborn?
Yes, yes. No, in general it is.
See,
In
ICT and DAT are going to answer different things. Now, you are trying to, if there's an ICT positive, it just establishes that yes, there is a antibody there in the serum, right? If the
Correct.
DAT is positive, it shows that the antibody is there on the red cell. So in that case, you have to know that whether the patient has been given any transfusion or not. So what are the cells which are actually carrying this antibody is important. So you have to see that in the light of proper history.
Okay. But in case of both negative and there is strong suspicion of hemolytic anemia, immune, how do you go
Immune
about?
hemolysis. So 3 to 10% cases can show a DAT negative. And if you're still suspecting you have a high suspicion, there are further sensitive techniques by which a DAT can be done. Or otherwise, you can repeat a DAT with a polyspecific, or you can have a polyspecific sera specifically, monospecific sera specifically, which contains IgA or something, which can help you know that yes, you're dealing with something unusual.
Okay.
So yes, 3 to 10% cases can have a negative DAT. You need to do a more sensitized technique.
Okay, like flow cytometry or what is
Yeah,
it?
flow cytometry, extended DAT. There are several techniques which can be done.
Okay. Thank you.
Okay. Yeah, I think there are no more questions. So thank you so much. Thank you, organizers, and thank you, Dr. Neeraj, for this opportunity. And I hope this will continue to be a wonderful learning platform for all of us. Thank you so much.
Next talk is Dr. Subhash Chandra.
This is the one.
हेलो नीरज सर। हेलो हेलो
Hello.
नीरज सर। हेलो
Neeraj sir is not here.
मैक आईफोन से नीरज सर ने ज्वाइन किया है। हेलो
हाँ जी।
सर ऐसा है, जो सुब्रत चंद्रा है सर, वो तो एयरपोर्ट पे बैठे हैं। वो फोन ही नहीं पिक कर रहे हैं, वो फोन काट दे रहे हैं। हेलो
मैं बोलूं?
सर को अनम्यूट कर दो।
Mr. Rohit, am I audible?
Yes, sir.
Yes, sir. So shall I start?
Yes.
Yes. ये remove this slide. नहीं, अब वो कर रहा है। अच्छा, what is the status? Is Dr. Subra joining? हाँ, रोहित। रोहित।
हाँ जी सर।
रोहित। हाँ, डॉक्टर सुब्रत ज्वाइन कर रहे हैं क्या?
एक मिनट सर। हेलो।
हाँ।
सुब्रत बोल कर रहा हूँ। इनकी पीपीटी हटा दो और ये स्लाइड हटा दो।
हाँ, ठीक है।
हाँ, हो गई चालू।
हाँ। Good afternoon, everyone. Good afternoon, everyone. Thanks to all of you for your wonderful participation. We are really thankful to all our esteemed faculty from different part of the country. Some people joined from All India Institute of Medical Sciences. Some people joined from PGI Chandigarh and University College of Medical Sciences, Maulana Medical College, King George Medical University, Lucknow, so various medical college all across the country. And I hope all of you will be benefited by their vast knowledge and their simple way of explaining everything. And thanks to all our delegates from all across the country who spared their time, who joined in this program to gain knowledge, and actively they participated in oral presentation, poster presentation, quiz. We're really thankful to all our organizers. Because of their hard work, it was possible to conduct this meeting, and our support system, IT person, Mr. Saurabh, his team, Rohit, Tripti, everyone worked hard to make this program successful. So now it is time to announce the results of different presentations. First, I will tell the result of poster presentation. First prize goes to Dhirendra Kumar Patel, DW018. His work was on cytomorphology of Phyllodes tumor of breast. Dhirendra Kumar Patel, first prize. Congratulations, Dhirendra. And second prize goes to Harshita Sharma. She presented a rare case, congenital epulis. Congratulations, Harshita. And in oral presentations, oral paper presentation, first prize goes to Vijit Zoon. His work was on an audit regarding assessment and platelet utilization in dengue cases in a tertiary care hospital. Congratulations, Vijit Zoon. And second prize in oral presentation goes to Rowena DL. Transfusion optimization in autoimmune hemolytic anemia. Insights from a case series analysis. Congratulations, Rowena. And now it is time to announce the results of quiz. First prize goes to Dr. Ananda Anand and also to Dr. Neeru Singhal. First prize goes to Dr. Ananda Anand and Dr. Neeru Singhal in quiz. Congratulations, Dr. Ananda, and congratulations, Dr. Neeru. Second prize goes to Dr. Pratibha. Congratulations, Pratibha. And third prize in quiz goes to Manish Kumar Yadav. Lot of congratulations to you, Dr. Ananda, Dr. Neeru Singhal, Dr. Pratibha, and Dr. Manish Kumar Yadav, and in fact to all our prize winners. So now, in the month of July, from 1st July to 5th July, we will conduct one hematology week. In that also, you will get the opportunity to present your study. You will get the opportunity to participate in the quiz and lot of academic sessions from brilliant faculty from all across the country. Looking forward to your wonderful participation in the coming program. So now we are concluding this session. Thank you very much. And if any of you want to say something, so please tell us to unmute you, or you unmute yourself and you can give your comment.
Thank you, sir and ma'am, for
Introduce yourself
teaching us all
first.
the 7 days in this week. But due to work hours, we are not able to listen to all the lectures. So will there be any recordings available
Yes,
for
you will
short
get
time?
you will get the recording of all the links. Whatever we discussed during the 7 days, you will get the link.
And it is valid up to which time, sir?
It will be valid for 3 months.
3 months.
Oh, yeah.
That was very kind of you. Thank you so much, sir.
Please introduce yourself.
I am Dr. T. Ramadevi.
Dr. T.
GCRI.
Ramadevi, DM Onco student of GCRI.
Yes, sir. Yes, sir.
Yeah, I was looking at your email which you shared with us.
Yes, sir. Thank you so much, sir. Thank you.
Anyone else? Okay. So now we are concluding this session. Looking forward to interact with you in the month of July, and regularly we conduct many other sessions also. Yes.
Yeah, hi sir, Saurabh this side.
Yeah.
Yeah, so if anybody has any doubt or if any have any query, they can also write us an email on Melap email ID, which is already there on the website.
ठीक है, फिर सौरभ अब conclude कर सकते हैं.
Okay, sir.
Thank you.
Thank you, everybody. Certificates you will get within 1 week. Within 1 week to 10 days on your registered email ID. Thank you.
Thank you.